और दीजिए। हेलो, yeah, just call up Dr. Bhalekar. Give me some Savlon. Nose drops. Yeah. Yeah. So a very good morning to all of you, especially to my ENT colleagues from New Mumbai. No problem. So very good morning to all of you, especially my colleagues from New Bombay, ENT Association, AY New Bombay. And this is the live surgery workshop on snoring and sleep apnea surgery. Today, 23rd of July, 2017. And this is the first case. He is a 38-year-old male with BMI of around 32 and AHI of 24. And I'm performing a drug-induced sleep endoscopy for him. So in the picture-in-picture mode, you can see this score को full कर सकते हैं. You can see the anatomy of this patient. That's the tongue base, that's the epiglottis, and this is the palate. And in the PIP, you can see the vitals of this patient. He's just getting into sleep. Dr. Kalpesh Sai is the anesthetist who has given sedation with dexmedetomidine and midazolam, and will take around 5, 6, 7 minutes for the patient to start snoring and going into apnea. So as we see his bispectral index monitoring, base monitoring, the level is still 97. That means the patient is fully awake. Full screen. Yeah. So obviously we are going to go very slow. At this point you are seeing that his base of the tongue is also collapsing, but it's not completely blocking the airway. Now if we look into the nose, you can see a gross deviated septum on the left side, which is high DNS on the left side. As you look onto the lower part, it's deviated to the right. I'll show it from the right side. If you see here, on the right side, there's a big spur, which is completely blocking the right nasal cavity here. This is the middle turbinate. So there's no space for us to go from the right side. So we'll have to tackle his DNS, the high DNS here, and the low DNS to the right, We'll possibly do that under navigation guidance so that you can understand the anatomy of the high deviated septum even better. And now as the patient is getting into sleep, as he starts snoring a little bit, you can see his palate collapsing here. And you see that his tongue is not really completely blocking the airway. It's mainly the soft palate. Okay. Now you can very, very clearly see that it is the soft palate. It's mainly the lateral collapse of the soft palate. So see, either let them decide or let me decide. Change. Sunil. So we understand very clearly that the problem here is mainly in the soft palate and the nose. You can see the bispectral index monitoring going out down to 85. That means we have not over sedated the patient. If there is any question on this, Dr. Sharad can pass on the question. Yeah, this is the perfect stage. You can see the patient grossly snoring, but still there is no collapse of tongue base. And this is the tonsil. I'll explain while operating. Can you see this tonsil coming together? This is the tonsil and this is the posterior pillar. Okay, so this is the posterior pillar with the palatopharyngeus muscle and the tonsil coming closer. So this is clearly a lateral type of collapse. But as we understand that if you only tackle the lateral collapse and pull it laterally, what will happen is that the palate will start collapsing anteroposteriorly. Okay, so at this stage you can see the tonsils coming very, very clearly together. At this stage I'll ask Dr. Kalpesh to start inducing the case. So you'll have to give us around 5-7 minutes for the preparation of the case. And this is the high deviated septum that I was talking about. Go into switch off the PIP, go into only endoscopy mode. Now I'm switching off the PIP, I'm only going into the endoscopy mode to show you things once again. Very clearly, this is the left nostril. Here you can see the patient into apnea because of the soft palate. There is no passage. And still at this point of time, the tongue base is not creating any collapse. You can see the larynx very, very well. So this is a clearly upper level obstruction because of the nose as well as the soft palate. Okay, and we have confirmed that at adequate sedation, the patient is not having any tongue base collapse. So I'll be taking questions now while Dr. Kalpesh is inducing the case. Can the camera move on to this side, and can this only come onto the camera? No, you go on to the external image, lights, external. Camera idhar go. One light. That's all right. Yeah. So, do we have questions from there? Now, so what is drug-induced sleep endoscopy? It will take around 5-7 minutes for Dr. Kalpesh to induce anesthesia, and definitely video laryngoscope. हाँ ये change कर दो. So, what is drug-induced sleep endoscopy? As we understand that in sleep apnea there are two types of obstruction. One is static, the other is dynamic. Now, static obstruction we can understand easily when the patient is awake, but for dynamic obstruction we have to take the patient under sleep. Then only we can video laryngoscope. Then only we can, unless we induce the patient into sleep, we cannot assess. You go on to that side. Less movements. We cannot assess where is the obstruction happening, and for that reason we have to take the patient under sleep, and that's called drug-induced sleep endoscopy, because you have to induce the sleep with some drugs. In this case, dexmedetomidine and midazolam are the commonest drugs which are being used. And now that we understand that this patient had only a nose and palate block obstruction, he didn't have any tongue-based obstruction. That means while we are inducing anesthesia, if we put a oral airway, then patient can be ventilated very easily when you relax the patient. So differentiating into upper segment and lower segment is the most important point that the drug-induced sleep endoscopy does. It's not the type of collapse, AP, lateral, circular, that is one, but the most important thing that you understand from drug-induced sleep endoscopy is differentiation of upper level and lower level blocks. Lower level is base tongue and epiglottis. So if some patient has a lower level problem, then the moment you induce anesthesia and relaxation, you will not be able to ventilate the patient. And that's the most important thing that we have to look at. In this patient, we know that it's only upper level problem. So we can ventilate the patient just like a CPAP, or we can put an oral airway so that there's enough space, the tongue doesn't fall, there's enough space behind the tongue, and we can induce anesthesia very safely. Any questions? You can forward me. Hi, Rahul. So we have Dr. Rahul Modi with us here, who will be moderating today's session of surgery. Give him the microphone. Microphone to Rahul. Give a microphone to Rahul. Okay, so in this case, what we are going to do, we are going to perform. Rahul, this is for you. Come ahead. So Dr. Rahul Modi has done a fellowship in sleep surgery at Stanford University, and is adequately trained in sleep surgery work, and I'll request him to moderate today's session. The first case, as we are going to do, Rahul, we just finished the drug-induced sleep endoscopy of this case. He's got a palatal collapse as well as a nasal deviated septum, and turbinoplasty will be required. Okay. Septoplasty, turbinoplasty, and uvulopalatopharyngoplasty of my technique. That's what we are going to do. Perfect. So, no, you have to speak in this. All right. So Rahul, I was just saying that when people have a lower level problem, then there's a problem in inducing. If it is only upper level problem, then generally induction is not a problem. Sure. And what is your understanding when people have a lower level obstruction, how good the CPAP can work? So, does the CPAP work? You have to bring it to. So does the CPAP work better in upper level obstruction or lower level obstruction?
So I feel in terms of CPAP working and the acceptability, if there is going to be a frank nasal obstruction, the patient is going to have an acutely deviated septum with enlarged turbinates. He may not tolerate CPAP well because he is going to require a huge amount of pressures to bypass the obstruction.
Yeah, okay. So, bispectral index monitoring, you want to talk?
Yeah, so one of the challenges when we do a drug-induced sleep endoscopy is to ensure a good plane of sedation. Am I audible there? Yeah, okay. So a good plane of sedation. There are a couple of methods you can do that. One is the BIS monitoring or the bispectral index monitoring, which kind of tells us in terms of the plane of anesthesia and which can guide us to whether we have adequately sedated the patient. Because if you are going to have a patient who is going to be a little light, you're not going to document all the obstructions. Whereas if you're going to have patient who's too deep, you'll see obstruction at every level.
Absolutely.
So what is important is to ensure, and that is why you need a very trained anesthetist. We have Dr. Kalpesha with us, who is very well experienced in these procedures. And this is what is required is a teamwork. You need to have a person who understands what level of sedation is required.
Yeah.
So one of the ways to monitor that is the BIS monitoring, which has these.
I'll show you the BIS monitor.
Yeah.
See, just show the sensor here. Now, as you can see, Dr. Kalpesh is inducing the patient. He has put this BIS strip onto the head of the patient. And as we predicted earlier that he will be able to ventilate the patient very easily. So even without much struggle, he is able to ventilate. And now you show the monitors. Now you can see the monitor is showing 100% saturation. And the BIS is showing around 52. Now, since he is being given anesthesia, the BIS is at 52. Now, when we did the drug-induced sleep endoscopy, it was in the region of 80, 75, 80, 75. So, 60 to 80 is the range where you give drug-induced sleep endoscopy, where you do drug-induced sleep endoscopy. 100 is the time when the person is fully awake. That means complete brain waves. 0 means no brain waves. That means a dead patient. And at 50, it's the time when you are inducing anesthesia. So this time we expect the tongue base to fall. Isn't that, Rahul?
Yeah, we expect the tongue base to fall. But
Yeah.
I mean, what we can also do is say something like a clinical assessment also. So, I mean, if somebody does not have a BIS, that does not mean that he cannot like do a drug-induced sleep endoscopy.
Absolutely.
So simple clinical measures. So once you are in the OT, there are two things you want to ensure. A, you want to see that the patient is sufficiently sedated. So a simple test just by calling out the patient's name can tell us whether the patient is sufficiently sedated. And you don't want the patient to be too sedated. So the patient should respond to a sternal rub, should respond to certain physical maneuvers, but should not respond.
You keep on.
Should not respond to a verbal stimuli. So that is the key here, that to establish that level and to maintain that level. So the challenge has been to find the perfect drug for that. Have we had the discussion for the drugs for sleep endoscopy? Okay. So initially, if you see, I mean, drug-induced sleep endoscopy is actually that way a very old technique. It was in 1991 when Croft and Pringle had described it. So the first drugs which were used were something like midazolam. Now the problem with midazolam was that it's a benzodiazepine, and as we all know, benzodiazepines are respiratory depressant drugs. So what used to happen in these patients is if you achieve, there is a good therapeutic window, meaning it's a safe drug even in patients with severe sleep apnea. But the challenge is to avoid respiratory depression, because at adequate levels the midazolam can cause some amount of respiratory depression. So that is why, I mean, it was there for around 10 years or so, but soon propofol took over.
Rahul, at this point of time,
Sure.
we'd like to show the intubation live, and we are using video laryngoscope now. You have to only show this external camera. Just show this. Just focus on the screen. Okay. If you are able to see now, see Dr. Kalpesh is already onto the cords. Without any maneuvering and under vision, he is passing on in the tube. Okay. So this makes the intubation very, very easy and predictable every time. Next case, we have a tongue base. Okay, so we can come back. The intubation is already done.
Okay, perfect job again,
come.
Dr. Kalpesh. Yeah. So coming back to the drug-induced sleep endoscopy, the second drug which was tried is propofol, which also still I would say is the most commonly used drug in a lot of centers. For drug-induced sleep endoscopy. Now, propofol is a good drug. There are two challenges with propofol. One is it has got a very small therapeutic window. In terms of if you give too much, the patient will go deep into anesthesia, and if you give too little, it will not have an adequate reflex. And what actually people found out that the more propofol you give, the earlier the genioglossus or the tongue reflexes go. So patients tend to have a lot of tongue-based collapse at very early stages of sedation. So it's very important to have something like a controlled infusion for propofol. The drug which is soon gaining favor in the last few years is something known as Presidex or dexmedetomidine. And I think it's becoming the #1 favorite for a lot of reasons. A, because it causes reliable sedation. I'm sure we are all aware of our anesthetists using Presidex in the OT regularly for all kinds of tympanoplasties, all kinds of local procedures in which sedation is required. The biggest advantage of Presidex being that it doesn't depress respiration at even deep levels of sedation. So it gives a pretty reliable picture. The challenge here is to...
It is a conscious sedation.
It's a conscious sedation, and the challenge is to kind of replicate natural sleep as far as possible so that you get a very natural picture while doing a drug-induced sleep endoscopy.
So now that our patient is already induced and Dr. Harsha is going to paint and drape the patient. So what we are going to do now, if we have a multi-level surgery to do, so like in this case we have a septoplasty, turbinoplasty and uvulopalatopharyngoplasty to be done. So what should be done first? So we should be taking the lowest lesion generally first. Like if we are doing the throat and the nose together, if you do the nose first, the problem is that the blood will keep trickling into the throat when you are operating. You pack the nose and then you'll have difficulty. So it's better to do the throat part first. So we'll do the uvulopalatopharyngoplasty. Have you packed the throat? Yes. So there's a little throat pack which I have asked Dr. Kalpesh to put in. If it is a very big throat pack, then obviously it will come in our way. A small throat pack will adequately prevent any flow of fluids into the trachea. In this case, since we are going to use coblation, there will be hardly any bleeding on the soft palate. But when we are doing septoplasty, that blood is going to trickle. So even if I do not put any throat pack while doing uvulopalatopharyngoplasty, it's fine because it's only saline. But if you're not sure that water will go inside, then you must use a throat pack. And because we anticipate some blood to trickle down while doing septoplasty and turbinoplasty, so throat pack is a must in almost all the procedures. Only while doing the tongue-based surgery, we have to remove the throat pack because it's that same area that we are operating. So we'll do the uvulopalatopharyngoplasty first. I'll explain on table when I'm doing that what is my logic of tackling both lateral and AP collapse in all the cases, because when we are seeing a drug-induced sleep endoscopy, the palate is a collapsible tube. So it may collapse in this way, it may collapse in this way. We have seen that even in the same patient, in different stages of drug-induced sleep endoscopy, depending upon the depth, the thing is changing, the pattern is changing. And we also know by our research, as I'll tell you in the lecture when I am there, that the structure causing lateral collapse and the AP collapse are essentially the same but in different configuration, which is the palatopharyngeus muscle. The medial part of the palatopharyngeus muscle causes the AP collapse, the lateral part causes lateral collapse. So this is one muscle which is dispensable. With the medial fibers and the lateral fibers are dispensable, only the vertical fibers are not. So we'll leave the vertical fibers and we'll remove the medial and the lateral fibers of palatopharyngeus, because all the techniques of palatal surgery revolve around tackling the palatopharyngeus, either suturing or just apply the mouth gag. So we are almost ready with the painting draping. I'll be using a microscope so that you are able to see a very, very clear picture. I always use the microscope so that I'll be able to show you different fibers. You'll be able to see the paratonsillar vein, everything, all the structures you'll be able to see. And so once we remove the upper part of the tonsil and the palatopharyngeus along with the uvula, obviously for the AP collapse, then we'll be able to tackle both the AP and the lateral collapse or even the circular collapse in almost all the patients. Are we ready with the, okay, can I just, so just give me a few minutes for the proper positioning of the patient.
So in the meanwhile, if there are any questions, the delegates can probably give it to the moderator in the hall who can pass it along to us, so that we can, as and when the time allows us, during the surgery, Dr. Vikas can answer those questions.
Okay, Dr. Sharath can actually call up on Rahul's number or Dr. Nilesh's number.
Yeah, so
yeah. What is the question, Rahul?
No, so I'm just checking if my mic is working or not. Actually, mic is working. Yeah. Okay. Perfect. Okay.
लंबा चाहिए, लंबा ब्लेड चाहिए. No. Why don't you talk about it?
So, see, what one needs to realize is AHI or one parameter, any one parameter when you're defining a patient or you're planning a treatment plan. Yeah. Any comorbidities? No comorbidities, no significant comorbidities in this patient.
He is only obese. His BMI is 32, I believe.
So what is important is again personalizing or phenotyping the therapy as per the patient profile. So a couple of things that you should look into. First is obviously whenever you get a sleep study done, you should look at the sleep study report in detail. We all know about an important metric, or one of the most important metrics is the apnea hypopnea index, which is the AHI. So the normal apnea hypopnea index is said to be less than 5 per hour. Mild sleep apnea is classified as 5 to 15 per hour, moderate is 15 to 30 per hour, and severe is said to be more than 30 per hour. But one must remember that the A component is very easy to define in these patients. It's very straightforward. You have a cessation of breathing for about 10 seconds and you can label the person as apnea. And the definition has largely been unchanged in the last 20 years or so. So it's one of the easiest thing to document. The challenge comes in measuring hypopnea. Now, the definitions that we all follow while classifying these patients is the American Academy of Sleep Medicine definition, and that definition has undergone 3 different changes. So, you may have a patient who's got an old sleep study done, and the hypopnea is different, and the apnea value can also differ between, say, from a level 3 study, which is like a home-based sleep study, to a level 1 study. So, another metric that one can judge while seeing at the sleep study is the oxygen desaturation index, and which also gives a true kind of a picture in terms of judging the severity of the disease. So if somebody is having oxygen desaturation where the oxygen levels are falling not so low, say they are in their late 80s or early 90s, I would not be worried too much about that patient in terms of his cardiovascular morbidity. But if I have a patient whose saturation is falling, so I mean 2 patients with the same AHI can have different oxygen desaturation indexes. So a person who say having an AHI of 70, but his oxygen is not desaturating a lot, his oxygen is desaturating only till 88% or 87%, would be at a lesser cardiovascular risk compared to a person, say, who is having oxygen desaturation almost as equal as the AHI, and the oxygen is falling down to early 60s or late 50s. So what you need to do in terms of counseling the patient, in terms of explaining the patient, you must highlight these points to the patient that your oxygen levels are falling so low, and that helps in deciding the therapy.
Okay, so I think I'm ready with the surgery. Yeah. Can you just now switch?
Yeah, so I'll just let Dr. Vikas to continue. I'll intermittently take questions and we'll be answering them.
Okay, so can we change the camera to the microscopic picture now? So now this is the microscopic picture going on. You can see that that's the soft palate. Is it in focus? Yeah. So you can see that this is the soft palate. This is the endotracheal tube. There is the throat pack there. This is the throat pack. This is the uvula. You can see that it's a big and redundant uvula. This is the tonsil, left tonsil. This is the anterior pillar, and that's the posterior pillar. Okay. So as you understand, the tonsil is between the anterior and the posterior pillar, and this is the three-dimensional structure which causes the block. So it is ultimately blocked at the level of the posterior pillar here, and the tonsil contributes into this. As you understand that this anterior pillar is not coming into the way of the airway. It's actually pulling the palate anteriorly and downwards, whereas the posterior pillar pulls the palate posteriorly and downwards. And the two muscles from top, levator palati and tensor palati, are like this. So as long as you do not damage these two muscles, you will not get a velopharyngeal insufficiency. Now there are various kinds of operators. Some people believe in preserving uvula. I am not a great uvula lover, so I am not very keen on preserving uvula. But how much of palate, if you have to remove, how much you can remove. Now I'll try to show you the hard palate here. I can. Okay. Yeah, repeat the question now.
So now there was a question. Yeah, this is a microscopic picture. We have the Zeiss Opme Vario attached to the camera, and that is how we prefer to do this surgery under magnification to identify all the important
What
structures.
is the question?
The question is whether the picture is from the microscope.
Yeah, okay.
Now, second question is there any special endotracheal tube which you use for intubation, and how do you proceed with it?
Now you can see it's a regular endotracheal tube. Yeah, and you have seen the intubation happening live. Now, how much of the soft palate can be sutured, removed, or done anything? So this is the junction of the hard palate and soft palate.
Right.
If you slide your finger down and go and touch the posterior pharyngeal wall, can you see here, Rahul?
Yeah, seen very well.
If you go and touch the posterior pharyngeal wall here, so this is the length of the palate which you cannot cut, remove, suture, anything.
Right.
Anything below that, if you remove, you will not get velopharyngeal insufficiency.
Right.
And if you see, in almost all the cases, your finger will go down and touch at a level which is, this is the anterior pillar, which is just above, almost half to 1 centimeter above the level of line joining the anterior pillar to anterior pillar. Can you see this is the line?
Yeah, just a second, Dr. Vikas, the voice is echoing. So if you can just adjust the mic for Dr. Vikas.
Just pull it up.
Yeah.
No, just pull this little up. Okay, now you let me know about my voice.
So Dr. Sharath, is the voice okay now? Alright, so we'll continue with the surgery.
Fine. So as you understand that this line connecting the anterior pillar to anterior pillar is generally always half to 1 centimeter below the point which goes and touches at the posterior pharyngeal wall. So this is the line generally that you can actually remove or do anything to the soft palate. And if you see in your drug-induced sleep endoscopy, most of the time this is the lower part of the soft palate, around 85 to 90% of the times, which is responsible for the collapse. If it is higher part of the palate still, which is called vertical palate, then the surgery is not going to work so well, and you have to definitely think of alternative treatments. So I am removing this uvula. This is the tube coming little in the way. So what we can do is possibly we can just push the throat back here. So I am removing the uvula in line with anterior pillar to anterior pillar. As you can see here, I am using coblation. The advantage of using coblation is that it will not give any fibrosis it will give a very good hemostasis and it will not give any fibrosis. So this is the anterior pillar to anterior pillar. I think we'll have to do something to the tube. No. Yeah. Give me a little bigger throat pack. I am just pushing a throat pack on the lateral side of this tube so that the tube remains out of my view. यहाँ से काट दीजिए. No, not now. Okay, so we want to keep the tube out of the way. We could have done nasal intubation, but we have to do the nose surgery. Therefore, we cannot do a nasal intubation. Now, this is what you see. There is a bloodless field with coblation, and you can see that there is no charring. And that's the most important point. If there is no charring, there will be no fibrosis, almost no fibrosis at the cut edge of the the palate. If there is a fibrosis here, it will act as a fibrotic band which will not let the palate move up. Now this is the musculus uvuli. Can you see the musculus uvuli very well?
Yeah, seen very well, Dr.
Yeah, this is the fibers going down. So I am cutting the musculus uvuli in midline. Now this much, if you see at the drug-induced sleep endoscopy, it's not the tip of the uvula, it's the base of the uvula. And this is the base of the uvula which is coming out.
Right, seen very well. Yeah. Very nice picture, huh?
Is the resolution going there is okay?
Yeah, we have checked the online feed. It's looking good. The voice is coming out to be clear.
No,
there is a slight delay, but
naturally that is going to happen. So now you see the musculus uvuli is completely gone. If you wanted to suture, you could have preserved this mucosa and sutured it like that. I am not a great fan of suturing because sutures give the maximum problems in the post-op period. So I am just cutting it here so that I can take the tissues on the left side first. Okay. So now this is the uvula and we come into the anterior pillar of the tonsil. Now there is no business removing the anterior pillar. So I'll just open up the anterior pillar to go into the supratonsillar pad of fat. Now can you see these are the fibers of the anterior pillar which we need not go into deep, and here I am into the supratonsillar pad of fat. Can you see that pad of fat?
Yeah, absolutely, seen very well.
And this is the posterior pillar. I'll just make it very, very clear to you. Can you see this is the posterior pillar?
Yeah.
Let me remove this and you can see the fibers, the direction of the fibers very clearly. Okay, can you see the fibers now very well?
Yeah, seen very well.
This is the pad of fat. So I am into the supratonsillar pad of fat and this is the palatopharyngeal fibers.
Right.
So I am cutting through the medial fibers of the palatopharyngeus muscle so that this part which was causing the AP collapse is gone. As we go more laterally, this is the pharyngeal wall. So this much part which I have cut was responsible for the AP collapse, and what I am going to cut now is responsible for the lateral collapse.
Right.
Now see, I have actually cut and removed the fibers of the palatopharyngeus. Now can you see the vertical fibers here?
Yeah, seen very well.
Just a little more of the oblique fibers. Let me remove. And I'll stop as I reach the lateral pharyngeal wall. Can you see that?
Yeah.
So I'm not damaging the mucosa of the lateral pharyngeal wall, because if I do that, then the patient will have velopharyngeal stenosis. Is that correct?
Yeah.
And that is the worst complication you can ever give, because then even the CPAP will be ineffective. So you have to stop when you reach the lateral pharyngeal wall, which is now. Right?
Right.
This is almost a 90-degree cut. Now see how much of the
soft palate is out.
And there's a lot of way created here. Now I will get into the tonsil from here. So this is the supratonsillar pad of fat. This is the anterior pillar muscle which I do not need to remove. So I will go into the tonsil. Now this is all supratonsillar pad of fat. Now I am entering the tonsil from here. Okay, can you see that? What is that?
The vein coming in.
Correct. So I'll buzz the vein. You can see it very, very well. And I'll get into the tonsil from here. Can you see the superior pole of the tonsil coming in here?
Yeah, seen very well.
So that's the superior pole of the tonsil. Now, here these are the vertical fibers of palatopharyngeus, which I need not actually cut them because they are going vertically down, right? So they are part of the lateral pharyngeal wall. So I have cut the oblique fiber still here. Can you see this?
Yeah.
So this is my plane of dissection. When I proceed, this is my plane of dissection.
Right.
I will not go lateral to it because these are the vertical fibers and they are part of the lateral pharyngeal wall. Now I'll change from a tooth forceps to a... Okay, is it visible?
Yeah, seen very well.
Now I'll take a lux forceps to hold the tonsil and do a tonsillectomy. Is the voice okay?
Yeah, voice is coming out.
Okay. Great. So now we know that technology is there to stay and we have to adapt to technology. Now you see that we are going lateral to the tonsil and this is the lower pole of the tonsil, correct? This is the lateral part of the tonsil which will remove completely. But as we go into the lower pole, see, have you seen the muscles at all? The muscles of the tonsillar fossa are not seen. This is the fascia.
Right.
So as long as you remain in the fascia, you will not get any big vessel. You will not get much pain. Right. The moment you enter into the muscle, there will be a lot of pain. So wherever we have cut the muscles, the patient will have pain. Wherever we have not, the patient will not have pain.
Right.
Now, this is the principle applicable mainly in small kids while doing tonsillectomy with coblation. Now you see, as we go laterally, we have taken out the whole tonsil.
Right.
And we are opening the tonsil like a book. But as we reach the lower pole, right, see, this is the lateral dissection of the tonsil over. As we reach the lower pole, this is the lower pole. Can you see that?
Yeah.
So where does the tonsillar artery comes?
At the lower pole.
The tonsillar artery comes at the lower pole. So if we know that in sleep apnea, the lower pole of the tonsil has almost no role to play. They cannot come closer enough to cause sleep apnea. So here I am going intracapsular so that I do not expose the lower pole of the tonsil. And if the tonsillar artery is not exposed, the chances of a secondary bleeding from the tonsillar artery is gone. I have never faced a secondary bleeding from the tonsillar artery for the last 3 years that I changed over to intracapsular surgery at the lower pole. Okay. So this is like taking a tie but without exposing the vessel. Now, can you see that oh shit, that was the lower pole of the tonsil and that was the tonsillar artery. By mistake it was exposed. This is what I did not want, but unfortunately it got exposed here. So anyway, I have stopped it. Now if at all you got the tonsillar artery, I was trying to avoid and unfortunately I exposed it. So what I should do now, the bleeding has stopped now, but it can always come back again. So see, what I have done here is to only touch the open end of the tonsillar artery, but the back of the tonsillar artery is still live. So what I'll do is I'll go behind the tonsillar artery and coagulate so that the whole artery is coagulated. Okay, and you can see one more vessel here. Can you see this?
Yeah.
So I'll coagulate that in the whole extent. So that was an accident, so need not bother. We know that if it happens, what to do. So that was just an accident. Our aim is not to expose the tonsillar artery. We know that the tonsillar artery was there. So we'll coagulate all around and behind the tonsillar artery so that the whole tonsillar artery length is coagulated. And then we know that once we do that, the bleeding will still not happen, because the caliber of the artery which is behind the open end has already been coagulated. Now there will be small vessels here, we need not bother about it. We'll get one big vessel in the posterior pillar. So now this is the posterior pillar, and we have removed the tonsil. Now here we have to now make a plane into the posterior pillar. Can you see the muscle coming?
Yeah.
Rahul?
Yeah. Seen very well.
Correct. So this is our plane. Now if we look at this part, there is still a little bit to be dissected out here. This is the tonsil, and when we are removing the posterior pillar, so this is the vertical fiber, clear?
Right.
And this is the oblique fiber. So whatever plane we have created, we'll continue in that plane and remove the oblique fibers. Okay.
Right.
So vertical fibers we are preserving, the oblique fibers we have removed. Now this is still a little bit of fibers here, tonsil dissection left, so I'll complete that. See, the space is so less, the tube is there, uvula is there, the tonsil is there. So now, okay, so this is the posterior pillar, and we have made our plane very, very clear here. So we'll see how much of mucosa needs to go. Can you see very clearly now?
Yeah.
Now there is no business damaging this mucosa, but this redundant mucosa, which was not solving any purpose and this was falling, this needs to go. So either you suture, when you take sutures, you suture it like this, correct, Rahul?
Yeah.
So I'm not doing any suturing, because sutures in my hands, they create more problem. They sometimes open up, they sometimes bleed, because when you're suturing, you do not know which vessel you are actually suturing into, and then when the patient coughs, they bleed. So I believe suturing doesn't do any great job. Now you see the oblique fibers which I'm cutting completely away.
Right.
And in next 2-3 minutes, the surgery on this side will be over. Okay, so this is the vertical fiber, this is the oblique fiber. Are the heads very, very clear?
Yeah, absolutely.
Right?
Seen very well. Seen
correct.
very well.
So now I am dividing it from here, and it's, see, can you see that small thing? Sometimes this vessel is really big.
Right.
So you have to coagulate that not only at the tip but also from the back. And that's the palatopharyngoplasty over. You see how much of tissue was removed from here, right?
Right.
So this tissue which was collapsing has already been removed. Now we know that this part was the reason for lateral collapse, correct?
Right.
Okay, can you see the paratonsillar vein?
Yeah, seen very well. Yeah.
Huge one, right?
Yeah, big one.
Big paratonsillar vein. Is it seen very, very clearly?
Yeah, seen very well. We have got good audio visual, Dr. Vikas.
Yeah, so I am coagulating it further, though it is behind the fascia. So there is no reason it should bleed. But paratonsillar vein, as I was telling you earlier, that before starting, that when we were not using microscopes and this technique, we never saw the paratonsillar vein. Now every single case we see the paratonsillar vein. So since we coagulated that, the flow in that vessel will also reduce, and I am just doing a little bit of coagulation all around, so that any small vessel which is there will coagulate and will not bleed. Tonsillar artery we have already gone and coagulated. Yeah, this was the tonsillar artery which we have already coagulated at the, in the entire course. Okay, so this is the lower pole of the tonsil which we have not completely removed. This is the coagulation of the vertical fiber of the palatopharyngeus, so that this will become fibrosed. When it becomes fibrosed, it cannot fibrose in this direction. The fibrosis will always be in this direction, which is good. Correct?
Right.
Now we shift the tube onto the other side. Dr. Kalpesh will shift the tube onto the other side. We'll come on to the other side. Yeah. We might have to shift the throat pack to the other side as well. So if you have any questions on this, you can definitely ask Dr. Rahul.
Right. So,
yeah.
couple of questions. So, one question that was there is what is the oxygen desaturation index?
Yeah.
Now, what happens is obviously when there is going to be any apnea, that is complete obstruction, or there is going to be partial obstruction, that is hypopnea, the patient stands a risk of some oxygen saturation falling. Now, there are multiple desaturation indices which have been used. So there is a 4% indice and a 3% indice. So what happens is, if the patient's baseline saturation is say 97%, and if his saturation is falling by about 4%, so the monitor will pick it up as an event. So it may so happen that each apnea, especially in younger individual, and each hypopnea may not cause an oxygen desaturation. Remember, apnea is just holding the breath for about 10 seconds. So there is no airflow for about 10 seconds. So I mean, we can all routinely do that, and I'm sure most of us will not have a desaturation. However, the severe apneas which last longer tend to have an oxygen desaturation. So typically younger individuals will have say, even if they have a high AHI, say maybe 30, 70, 80, or however high, they generally oxygen desaturation index is not so bad. So they may not desaturate with every obstruction happening. Whereas if you see an older individual, person in their 50s, and that is what you need to look for, is the oxygen desaturation index. So you may have an AHI of 50 with an ODI of 50 again. Now, what is important to know that multiple studies have shown that AHI is not a very sensitive marker in terms of predicting cardiovascular morbidity and mortality. So patients who have ODI, severe ODI, tend to have more cardiovascular events. We'll go back to the surgery now and then we'll resume this discussion. I'll request anybody having questions to post it on the AOI Navi Mumbai WhatsApp group.
So very nice. Thank you, Rahul. Now see, we have done the left side. Now see how much is the difference already created. And we saw that in our sleep endoscopy, that this was the area causing the maximum problem. So now we are going to the right side. This is the right tonsil. Is the picture good?
Yeah.
Is it centralized?
Yeah, very well seen.
Okay. So this is the anterior pillar. So we are only going to enter the anterior pillar, not completely remove it. So that we go into the supratonsillar pad of fat again. See, there is sometimes a vessel at the upper pole of the tonsil also, and you have to be careful about it because it can cause really nasty bleeding in the secondary bleeding in the post-op period. But most of the time it is the tonsillar artery which is the trouble. Now can you see this? This is the lateral part of the tonsil.
Right.
I am already lateral to the tonsil, and this is the posterior pillar. Can you see that?
Yeah.
So now this is the part of the supratonsillar pad of fat which I have removed and entered the tonsil. As I go behind, here I am just going laterally first. Do a routine. See how much is the lateral component of the tonsil here. So you have to remove this because this is in the upper part of the tonsil. Now see, this is the tonsillar fossa and this is the posterior pillar.
Right.
So which muscle is this, Rahul, now?
The palatopharyngeus.
Palatopharyngeus. So we have to cut this palatopharyngeus without any fear, because the job of this palatopharyngeus muscle is to pull the palate down and behind, which we do not want, right? Only thing is that you do not have to get into the lateral pharyngeal wall. So you have to know what is your limit. So when you lift it like this, can you see this?
Yeah.
So you have to cut it here.
Right.
If you cut it here, it will not make any purpose, because this is the bottleneck area.
Right.
So you have to cut it here.
Right. So now question, Dr. Vikas, is the supratonsillar fat, do you always remove it? Do you recommend always removing it, and do you always find it?
So unless you go into the supratonsillar area,
Right.
see, it's this area which is the bottleneck. This is the velopharynx.
Right.
So if you see how much lateralization has happened, see this?
Right.
Now whether you suture this here,
Right.
which many people do,
Right.
or you cut it.
Right.
So unless you take this incision onto the, see this, these are all muscles, the oblique
Yeah.
fibers. You'll not get a complete opening of this area.
Right.
So you can suture this like this, or you can suture it like this, whatever ways, or you remove it. I prefer removing it,
Right.
so that there's no ambiguity on it falling back again, or yeah. So see, I'm removing it here.
Right.
I'm not removing the vertical part. Vertical part is this.
Right.
And since this angle is 90 degree, can you see this?
Right.
This angle is absolutely 90
Yeah.
degree. So it will close like this.
Right.
But the fibrosis in the vertical part is going to happen vertically.
Right.
It's not going to happen like this. So this will never ever cause a velopharyngeal stenosis. And if you use cautery to do the same, you may still get a stenosis.
Sure, because there will be a lot of
Yes,
charring.
lot of charring. So let me just finish off the palatal part here.
Right.
Okay, so this is the tonsil. Now, any small vessel here you can coagulate, but the wand should be directed towards the tonsil and not towards the fossa.
Right. Very, very important point there, because technology is as good as you use it. If you are going to dig the coblation wand into the tonsillar bed, it will induce bleeding.
See what I did on the other side accidentally. Right. See, I hit the tonsillar artery only accidentally, because there was some movement here and I couldn't control. So you have to be really careful. So if that happens, you know what to do. That's why live surgery workshops are, so that in real life situations, whatever you face, you still have to tackle it. Now this is the lower pole of the tonsil, correct?
Right.
So here I expect the tonsillar artery somewhere here.
Right.
So I'll be, sister, don't move at all. ठीक है, कोई movement मत करिएगा. So now we know that this side we do not have to expose the tonsillar artery. So what I am doing is I am leaving the lower pole of the tonsil and going intracapsular here. So now this is the tonsillar tissue.
Right.
I am going inside the tonsillar tissue, making sure that I don't hit the tonsillar artery. Obviously at this point of time there should not be any unnecessary movement, because that your control will get lost otherwise. Okay.
Right.
See, I have just left a little bit of tonsil which I am.
And that is by design, right? I mean, you want to leave a little bit of tissue there. Yeah.
See, this is not a case of tonsillitis, right?
Right.
This was a case of sleep apnea, and I'm just not exposing my tonsillar artery. I'm just leaving a little bit tissue over here to protect my tonsillar artery. So see, on table you can tackle whatever is there.
Right.
But when a patient has gone home and after 7-8 days, if he has a secondary bleeding,
right,
these are the, yeah, can you see the fibers?
Yeah,
these
very
are
well.
Vertical fibers.
Yeah.
These are the oblique fiber. This is the oblique fiber, correct?
Right.
So I'm going between the vertical fiber and the oblique fiber here to get my plane. And as I told you, there will be a small vessel here which sometimes can be nasty.
Yeah, especially from the posterior pillar.
Yes, from here. So if you get a vessel here, you have to coagulate not only the tip of the vessel but also the course of the vessel. Because once you coagulate the course of the vessel, the caliber of the vessel will go down. Okay. And then it will not have sufficient pressure to cause a secondary bleeding which has to be tackled in the theatre.
Right.
So our surgery is over.
Fantastic. Yeah. So no suturing for the palate?
No suturing.
Okay.
Kalpesh, approximately how much time we took for the surgery? 30 minutes? So 30 minutes we took for the surgery. Now there is no suturing. Time is no consideration. But see, the longer you give the anesthesia, the bigger are problems, right? So you also want to reduce anesthesia time. You want to do the work faster, and even with demo, we could finish it in 30 minutes without hurrying up at all. Now you see, so this is the final extent of the surgery. I'll try to centralize. This is the final extent of the surgery. You can see the posterior pillar here.
Right.
This is cut at 90-degree angles.
Right.
Right. So this is 90 degrees, and just to take care of the the uvular artery, I am coagulating little more in this area. Now we know that we have not done anything to this palate, so this palate is absolutely soft. So the movement and the length of this palate is sufficient, right? It is going and touching.
Absolutely.
So we have underdone, we have not overdone.
Yeah, that's very important.
So
see, essentially
you can always revise it, do
absolutely
something.
Absolutely.
You should not overdo the things.
Right.
Now I'll shift on to the yes, apply. Now we'll have to isko shift karo. Come on to the external camera.
Yeah.
Where is Sunil?
Yeah, so there is a wide round of applause for you, Dr. Vikas, on the WhatsApp group. So great job there. So I mean, we can take a few questions. A couple of things about.
Till we are shifting on to the.
Till we are shifting on to the external camera, and for the. Yeah, just a second. Now, in terms of palatoplasty, if one goes through the literature, one goes online and tries to look for palatoplasty, I think we'll find at least 200 types of palatoplasties, if not more. So there is the zeta palatoplasty, there is the expansion sphincter pharyngoplasty, there is a advancement palatoplasty, and essentially what they try to address is both the AP collapse and the lateral collapse. So the idea is again reshaping the palate. The idea is again creating or removing that obstruction, creating that space depending upon what the obstruction is, and tackling that obstruction. So one method which was demonstrated here is excision of the palatal muscle. Typically there are other ways also to achieve the same. Idea is the same. I mean, so if you go through the literature, the most important part of the entire procedure is removal of tonsils, and your success depends upon selecting the right patient also. So you will always find patients with big tonsils obstructing grade 3, grade 4 doing very well after a palatoplasty compared to the patients who are having not so big tonsil, something like a grade 1 tonsil or a grade 2 tonsil. So one must always be in terms of very smart in selecting these patients, counseling them for surgeries. During the palatoplasty, one of the popular methods to do that is something known as the expansion sphincter palatoplasty, which is slightly different from what Dr. Vikas has demonstrated. Yeah, so which is slightly different from what Dr. Vikas has demonstrated, where you do the tonsillectomy same as before. You have to remove the supratonsillar pad of fat, but instead of removing the palatopharyngeus muscle, you can just cut out the lower part of the palatopharyngeus muscle, dissect it out like a bundle. So you can just, if the palatopharyngeus muscle is going down, you can just cut the lower part of it, dissect out the muscle up, and then you can suture it to the pterygoid annulus or the pterygoid raphe superolaterally. Idea is to create a tension so that the walls, the lateral walls are tensed out, and there is space posteriorly as well as laterally, and the partial uvulectomy which is done takes care of the anteroposterior collapse. And what is important is when you are doing these procedures to try and avoid or minimize the raw areas.
Endoscopy.
The more raw areas you create during surgeries, the more unintended complications happen and the more chances of stenosis happen. Are we ready, Dr. Vikas?
No, we have still few minutes.
Okay.
So I'm using navigation,
right,
even for septoplasty, so that I can demonstrate high septal deviation.
Right, right.
We'll try to demonstrate high septal deviation. Where is the septum? How much is to be removed?
Right.
You-
So
you
we are just
continue
setting up
talking.
the navigation unit and to have everything in place for everybody to see. So, Dr. Vikas, any experience with radio frequency? Because I have never used radio frequency. I've used coblator, but there's a question from the house in terms of whether you prefer radio frequency in this patient.
I am a fan of coblation.
Sure.
But radio frequency for the turbinates is good.
Right.
Radio frequency is good for the turbinates. It's not so good for the soft palate in my view, because again it works on the thermal principle. It works on the thermal principle, and in soft palate I do not think we should be giving any thermal injury, because that induces more of fibrosis. So I do not prefer radio frequency at all.
Right.
And fibrosis, whatever you create, after 6 to 8 months, the fibrosis, or maybe 1 year, the fibrosis tends to reverse, to soften. So anything which you do on fibrotic principles may not last long, and has happened to me earlier. Therefore, I do not really believe into it. Okay, are we on? Chalo. Just give me 1 second. I'm setting
Sure.
up the navigation unit for you, so that you can see the high septal deviation. Now, septoplasty is, I know many people will not be greatly interested in learning, but I'll show you some things which most of us, at least I did not know till a few years back. And there's always a scare while doing high septoplasty. When you're going high, there's always a scare. So why don't you set up it fast? So we are moving on to the septoplasty and turbinoplasty part.
Sure.
The next case we have a palate and tongue base. So we'll again discuss on the palate and tongue base again.
Perfect.
Now the nose is equally important for obstructive sleep apnea.
Absolutely.
And what we have to understand, that the flow of air, just check out if my sound is okay. If there is any problem with the sound, you let me know. So the flow of, suppose if this is the nose, the flow doesn't go along the floor. It goes at the internal nasal valve, which is formed by the septum and the upper lateral cartilage. So
Perfect.
And goes along the nasal valve into the area of the middle turbinate, and then goes down at the posterior quina. So the bottleneck areas are, it's not really along the inferior turbinate. The bottleneck areas are the entry point, the internal nasal valve. So if there is a blockage, the patient will have a lot of blockage. If the middle turbinate is big, concha bullosa, there will be a blockage. If the posterior quina is blocked, either by adenoids or by the posterior end of the inferior turbinate, that is the problem.
Right.
Now the inferior turbinate also plays a big role along the entire extent, because the inferior turbinate has 3 parts: anterior 1/3, middle 1/3, and posterior 1/3. Posterior 1/3 is bulbous, which will swell and block. Anterior 1/3, the upper part is bulbous, the lower part is polypoidal, and the middle turbinate, upper part is again, the middle part is bony, lower part is polypoidal. So the whole of inferior strip of the inferior turbinate is polypoidal, and that polypoidal thing will respond to allergy more. So if you remove that polypoidal part, the allergy will stop blocking the nose. The patient will still have sneezing and watering, but the blockage of the nose will reduce a lot. So in this case, I'll try to show you how a airway surgery mainly for the blockage part can be performed while reducing the effect of allergy onto the nose, because allergy is something that we cannot really.
Right. So
Okay, why don't you show the
tracker? So can we have it on the navigation device?
वापस से setup equipment. Okay, Sunil, can you show the navigation once? नहीं, तुम अपना काम करते रहो. Okay, so this is the navigation system. We have already put this. इसको ऊंचा करो. ये जो है ना, ये, हाँ, इसको ऊंचा करो. नहीं, ऊंचा करो, इसको ऊपर लेकर के जाओ. नो, अच्छा, चल, छोड़ दो. हाँ, उसको ऊंचा करो. So this is the navigation unit. नहीं, उसने बराबर लिया नहीं. कोई बात नहीं, छोड़ दो तुम. पेशेंट ट्रैकर नहीं आ रहा है ना इसमें, थोड़ा इसको पास लाओ, शॉन, इसको पास लाओ. Just give me a moment so that, बस, that's it. So, okay, now you can see that both registration probe and the patient tracker. Focus on that, Sunil. Fix it. Both are in range, right? Both have become green. Show, Sunil. So there is a registration probe and there is a patient tracker. Focus it. Focus it. Okay. Now you show here, Sunil. Move the camera here. Now you are seeing this is the patient tracker. Go down. Okay, and this is the instrument tracker. Now I am marking. So I'll be moving the instrument. It's not taking. It's just not taking. So there is some technical issue here. I'm just trying to track. If it takes, fine. Okay. Now you show it there. Now see. So whatever I tracked, it has already taken. I go to next. Now we are getting all the window. So this is the. Now this is the sagittal, axial and cornal, all the views. So we'll take the cornal on the. Okay, it's alright. It's alright. Okay, it's fine. It's fine. Chalo, change the window. Now what we'll do is we'll just take the cornal on the top because that's the most common one I'm going to show. And you can fix the camera. Don't move the camera. Fix it on the. Okay. Now we know that. See, this is the cornal picture. Wherever I am tracing, it's taking. Now we'll take endoscope. Suction. It just takes a few seconds to align everything. Generally, it's a 2-minute job to align everything. Camera, endoscope. Now I'll take a 0-degree endoscope, and you can go to the endoscopic picture now. In fact, you can go PIP. Shawan, PIP करो जैसे करते हो. Light दो, endoscopic light दो. Endoscope light source on. Light बढ़ा. Are you getting the endoscopic picture? And with the PIP, I'll be showing you the navigation. Okay, now Sunil, can you focus on the cornal, the upper left corner? Upper left corner, yes, this one. Okay, so what I am showing you is the septum. See, this is the internal nasal valve area. The septum is here. If you do not take care of this part, the patient will not have an open nose because this wall is constant and this is the septum deviated on this side, on the left side. So if you do not tackle the high septum, the patient will not do well, right? And where is this high septum? It's not near the skull base at all. If you see on the navigation screen, it's below the frontal sinus, correct? See, this is the middle turbinate here. Middle turbinate is here, and see the septum here is so low. So if you remove this part of the septum, there's no way you can damage the skull base. If you do not remove this part of the septum, then this middle turbinate area will not open. This functional endoscopic sinus surgery will not work. The patient will not have an open nose. So even if the nose looks open like this, this is the most critical area we have to work on. Now, give me infiltration. Local. दूसरा tracker. Yes. Shift the PIP नीचे. ये दूसरा दीजिए. ये दूसरा निकालिए. अच्छा, चलिए कोई बात नहीं. एक मिनट जाना दीजिए इसको. उसको हटाइए, दूसरा निकाल करके. और बाहर नहीं जाता है. PIP बंद कर दो ना, अभी अपने को जरूरत नहीं है. Yes. Chali local. So we understand. I'm infiltrating. I'll do an endoscopic septoplasty so that all of you can see. I'm infiltrating the lower part. I'm infiltrating the higher part. And the anteriormost part. I'll infiltrate on the other side. There is hardly anything in the sinuses in this patient, but we see that the right side is completely blocked. So we'll start off with the septoplasty. Sir, कौन दीजिए ना? चलिए. Now we'll try to do everything endoscopic so that you can see. Suction is ready. Septoplasty suction. Yeah.
Yeah, if there are any questions, please feel free to write them on the WhatsApp group so we can take them whenever there is a break.
You can take them. This part of chili.
Yeah, so what we'll do is, so there are a couple of questions. We have Dr. Kalpesh Shah with us. He is our anesthetist. And Dr. Kalpesh, regarding these patients, what are, like in terms of a center which is going to start this surgery for the first time, and what should the ENT surgeon tell his anesthetist, or what should the anesthetist preempt in these patients? Any special points apart from expecting a difficult intubation?
Good morning, friends. It's a warm welcome from all of you on behalf of Specialty ENT and Dr. Vikas Agrawal here. Anesthesia is a very important and vital part of this kind of surgeries. You all know very well about it. I would just say that there are few points which is very important. One of them is anticipating a difficult ventilation in these patients. And this anticipation of difficult ventilation as well as intubation can be only done in collaboration with the ENT surgeon and with the DIAS when it is happening. So this technology and this modality is to understand is the first step of pre-operative assessment of the patient. Apart from this, there are a lot of comorbidities these patients do have. So we need to look at all the comorbid conditions because these patients are not only obese, but they are generally suffering from hypertension and diabetes also. After considering these issues, we really need a good hemodynamic control intraoperatively, and for that we need to have a good control of the anesthesia agents going. I would say that the first thing, the requirement for this is a good anesthesia workstation and monitoring system, because these two things are going to give the accuracy in anesthesia. Good anesthesia workstation will give the complete and perfect ventilation, and monitoring system in the terms of anesthesia gas monitoring system, which measures the how much inhalation anesthetic agents are going, and the BIS monitoring system, which tells us about the depth of the anesthesia. These two monitoring systems are really going to help you in fine-tuning the anesthesia, and believe me, these are the equipments which are giving us a good outcome of the patients. After reaching to the end of the surgery, here is another role of a good extubation, because anticipated difficult intubation is always a anticipated difficult extubation. In this scenario also, good hemodynamic control, absolutely awake and comfortable patient is the prime requirement. And immediate post-operatively, if we have something like a CPAP, I will show you, we have some disposable CPAP system which is very cheap and very easy for a patient to manage, which can increase the oxygenation of the patient in post-operative period. So this is a whole combination of a teamwork as well as understanding the whole paradigm of the OSA patients.
Okay, so here we are. As you have seen, we have already lifted the flap, and I am now lifting the flap onto the other side. See, I have not gone till the junction of the bone and the cartilage. I am removing this much of the cartilage because this is the high cartilage deviation. If we do not remove it, the patient will not get a relief. Now, how much of cartilage you can remove? You can remove the cartilage, anything which is behind this anterior nasal spine and the junction of the nasal cartilage with the nasal bones. Anything behind you can remove, and see, you have to be in the correct plane. See, if you are in the correct plane, there is no bleeding. If you leave even this little bit of layer of perichondrium, it will keep on bleeding. If you are in the correct plane, it is as bloodless as this. Right?
Yeah, excellent demonstration, Dr.
Yeah. So now, as we saw that this part, and if you go very high and remove the part of the cartilage which is below this nasal bone, then there will be no problem. But if you come ahead, there will be a problem. And you see this cartilage, how is the tilt? Right, this cartilage is like this. So if I go behind and remove, do it from here, it will not work. It will still remain. So
right.
So I have removed, I have come quite anterior, as you can see here, but he will not get any deformity because I am below the nasal bones. Yeah, and this is the area of the internal nasal valve if I do not remove that. And I'll show you in a minute that where is that area actually onto the navigation. So that time we'll go PIP once again.
Right.
Okay, can you see this? This is the cartilage. How much of cartilage I have removed? But believe me, there will be no problem of shape at all. Even if I come anterior, I'll just leave this part which is below the cartilage. If you do not remove this is the upper lateral cartilage. I'll just show you. This is the upper lateral cartilage. So this is the upper lateral cartilage, and that's where the nasal bones start, right? So now I'll show you on navigation where do we stand. Now this is the bone. I have already reached the bone. Sunil, bahar kyun jata hai? Why are you outstanding? Stand here. Okay, now I'll show you on PIP. Suction एक और लगाइए ना, ये वाला लगाओ. Suction please. Where is this part? I'll just show you. Yeah, on the nahi, it's not perfect. Only the cornal one. Only the cornal. Yeah. नहीं, cornal. Now see, पूरा Shravan तुम करो. Let Shravan do it. Shravan तुम करो. Okay, now see, this is the bone. Where do we stand? It's so low, right? It's below the frontal sinus. Can you see that? I'm tracing it up. It's below the frontal sinus. There's no skull base around. So now as you go behind, see, this is still the frontal sinus. Show it. अभी ये दिखाओ. Sagittal. Now see where we are. We are very, very low. We are nowhere near the skull base. Correct? Now go back to cornal. Okay, give me lux forceps. So I am. See, this is the lower part. So I'll remove the lower part anyways. Now this part is very low. You have no problems in removing it. On the scan, you know that we are very, very low. So you can simply remove it without any fear. The moment you remove it, now again I'll show you. That's the bone. Now see where is that bone. Show on the cornal. Cornal you are showing, right? Show on the sagittal now. See sagittal, how low we are. We are well miles and miles below the skull base, right? Now see, this is the thick bone. Go back to. Bas. Is it light? So see, this is the thick bone which is below the frontal sinus, and it's only the thin bone which is below the skull base. See it, right? Now if I go so behind and so up, still it is below the frontal sinus. So there is no problem in breaking and removing this bone. Okay, this is the message which I wanted to give, that if you don't get scared of skull base here. There is no skull base here. And remove this upper septum completely so that you get a very, very clear airway as well as the sinus area. Now when you reach this part, suction. When you reach the thin bony part, see that? This bone is thin. Now as you go high in this part, definitely you will get the skull base. So what you should do, you can actually use a scissor to cut it, because this is a very thin bone. You can simply cut this bone. Okay. So under no circumstance you are going to injure the skull base. Let me remove that part. So I have already cut. Now I am removing this part. Now let's see where do we stand. Okay. Now let me come out and chhod do. Give it. Now can you see this? Can you see this? Middle turbinate was not seen. Now this whole area, this is the skull base there. Can you see that? Yeah. So we have opened up the internal nasal valve completely. You can see the skull base. You can see the middle turbinate, which is a little, paradoxically curved. Lower part of the septum, again, I have not removed. I'll remove the lower part of the septum because that's deviated onto the right side. Now I'll go for the lower part. Suction, please. So the idea is that unless you do a high septoplasty properly, your results of septoplasty will not be good either for sinus or for the airway. Okay, Lux, please. So I am removing the lower part of the septum, which is not really deviated anteriorly, but in order to go posteriorly and remove it completely. This is the thin bony septum, which we had already. Now see, here it is deviated onto the right side. Septoplasty suction ready hai kya? So I'll use a septoplasty suction elevator to clean my flaps. Now you see that. So one side flap, because this is very sharp, it is bound to tear, right? Even if you try your best, it will still tear. So there is no point trying to save that. Important thing is to save the flap onto the other side. Can you see it's completely saved? So if you save the flap onto the other side, then definitely it will not cause any septal perforation. Now this is bound to tear, so don't cry over that. If the other side is good, then there will be no problem. Yeah, go into single pick. Remove the PIP. Okay. So we have gone right till the back. Rostrum of the sphenoid is somewhere here. So we need not go and remove the rostrum in this case. If required, you can also remove the rostrum. Here in this case, it's not required. So I have done a complete septoplasty, only preserving the anterior part. And you have seen how much is the airway open. Can you leave that? Sure. Debrider ready, suction ready. Okay, so this is the complete passage here. Now since there is no sinus problem, I will not do anything to the middle turbinate, though I can do a 3-cut technique and medialize it. But possibly since there is no problem with the sinuses, I will just leave it here. This is the other side. Now you see the septum, the turbinate on this side. Channeling wala want hai kya? So you can do either channeling of the turbinate or you can do a turbinoplasty. Possibly I'll demonstrate a turbinoplasty here. It's not going to look so impressive, but I'll explain you the different. Ye chalu hai? Debrider chalu. Suction cautery ready kariye, check kariye. Now see, this turbinate has got 3 parts. This part is totally polypoidal. As I told you earlier, the posterior part is completely polypoidal. And you see how much of secretions are forming here. The lower part is polypoidal in the whole extent. There is no bone here. So this will keep on reacting to allergy. And the anterior part is bulbous here, which will form the the internal nasal valve on both sides. So this is the, now see this is the polypoidal part, this is the polypoidal part, this is the bulbous part, this is the bony part. So upper part bulbous, bony and polypoidal, lower part polypoidal, polypoidal and polypoidal. So 6 parts we divide our inferior turbinate into. And now this is going to bleed. Give me debrider. So I'll debride the, I have not injected into the turbinate, so it's going to bleed. Suction cautery check किया और coblation भी लगेगा, coblation भी ready रखिए. See, I'm just checking on my suction cautery. Yeah, it's working fine. So what I'll do is I'll start from the posterior most part. Let me start on the right side. It's definitely gonna bleed. So please forgive me for the bleeding. So I'm just debriding. See, this is all polypoidal. There's no bone into it. Can you see that? And how much is the choana opened? Okay, so I have debrided the posterior part. Then I am debriding the lower part of the entire length. There will be some bleeding. We don't have to bother about the bleeding because we have not injected also. So injecting adrenaline is more of a trouble. And see how much of this space is open. Give me the coblation wand. Suction लगाइए. Coblation चालू है. See the anterior part. Coblation ready. The anterior upper part. This is the bulbous part. This I am just coagulating. So you can do a submucosal diathermy as well. But I have realized that doing this, though there is a little loss of mucosa, but this is much more easy on the patient than doing a cautery. Now see, till this part, the moment you open up this part, his nasal valve will remain open. This is the third turbinate on the septum. If this is very big, we can coblate here also. And give me suction cautery. Whatever part we have already removed, ये दे दीजिए, will cauterize. But before that, so see, upper part of the anterior 1/3 we have done, lower part of anterior 1/3 we have done, middle turbinate, middle part of the inferior turbinate will just out fracture. The moment you out fracture, you create a lot of space. So if we understand the inferior turbinate into 6 parts, we can give the patient an absolutely open nose without giving any chance for atrophic rhinitis. So this I am just cauterizing. Superficial cautery to stop that ooze should be enough. I have not exposed any vessel. Now this mucosa is supposed to be lost. The mucosa of the upper part of the inferior turbinate is important. The lower part is polypoidal. This mucosa, if you leave there, this will keep on reacting to allergy and the patient will keep on having problem. If you want, you can remove this part of the bone as well, which if it is big, many times I do. Otherwise, you can just leave it here. So this will keep the posterior choana open, the anterior, the path of the airway is open and this allergic mucosa is gone. And this is not going to bleed heavily at any, there's no chance of a heavy bleeding. Same thing I'll do on to the other side. You can do a simple channeling as well, but I'm just showing this that you have seen many a times. I'm showing you something new which you can do for bigger turbinates. As we said that this is only polypoidal. Now this is a simple regular 0-degree blade of Medtronic shaver. So this mucosa is absolutely not useful. It creates problems. And if the bone is big, I'll remove the bone also. But here the bone is not really big, so I'm not removing the bone. So if required, you can outfracture the turbinate, remove the mucosa, because the mucosa which is on the lower edge, and if you scissor dijiye, and I'm just showing, I'm not removing. If required, you can just cut away this bone like this. Okay. So here it's not big. I'll just demonstrate that you can cut a small part of the bone like this. So if the bone is very big, you can just remove this part of the bone. You save all the mucosa which is useful. Suction cautery. What happens is here, when you cut the bone, I'll just show you where. See, here it's not bleeding heavily, but see, there's no heavy bleeding here. But if you go into this part of the bone, the inferior turbinate blood supply comes from there, and then you can have a heavy bleeding. You can do coblation, you can do cautery. Cautery is much faster and easier, and on the bone, cautery works better than coblation. Suction. And the middle part, obviously, we should always lateralize. So the moment we outfracture the inferior turbinate middle part, you can see how much space has been created, and we have almost saved all of the turbinate except the part which was not useful. And we'll just do a suction cautery here. Now packing with suture packing airway wali. Now I'll show you another thing. Now all the OSA patients, when you do the nose pack, when you have done so much, you have to do the nose packing. First of all, why we are doing the nose together? Because this patient's tongue was not big, correct? If the tongue is big, you cannot do a nose packing in this patient. And even if the tongue is not big, obviously with so much of surgery, we have to pack the nose. So we have to know what kind of nasal packing will be required. Chile, suture, gel foam and packing. So first of all, I am suturing. Now we just check inside that there's no bleeding. There's no active bleeding inside the septum. Then we'll suture the septum. Now the packing will only happen like this. So the upper part of the septum where we have operated may not get covered, and there may be hematoma formation. So I'll tell you how to prevent that also. So first of all, now I am putting gel foam soaked with a hemostat, Sepguard, to take care of the upper part of the septum from forming a hematoma. Because your pack is not going to be there. We are going to use either Nasal or I'm going to use rapid rhino with an airway. I'll show you that so that the patient can still breathe, but the upper part of the septum or even the sinuses you cannot take care of with the pack. So if you put some gel foam with Sepguard, is the sound okay or still going? So if you do that, make them clearer. So if you do that, then you will not get hematoma formation in the upper part of the septum. And this is simple gel foam. It doesn't cause any reaction even if you put it into the open sinuses. I routinely do it. This case obviously is not a sinus case, but so this is the part done to prevent a septal hematoma in the upper part of the septum where we have operated. Now we'll take sutures and then we'll show you the rapid rhino. Can you show this? We'll just take 2 sutures to keep the flaps in place. Dikhaiye, dikhao. Is it visible? Harsha? Just 2 sutures to keep the flaps in place. Not that it really matters. Cut it. Cut it. So just 1 sec to finish off this suture. Even 1 should be alright, but We can always take 2. This is a chromic catgut, so it will fall off by itself, need not be removed. Cut kariye. Now go to external camera. Now we are going to external camera. External camera should be shown here. दिखाइए. Focus on this. I can. Now see, this is rapid rhino. Okay. So this has got a hole. Can you see that hole? Can you zoom on further? Okay. So this is the small airway, and this is coated by CMC, carboxymethyl cellulose, and then this has got a और अपना measure करने वाला. This has got the bulb which can be inflated. So what I am going to do is I am going to put it inside and then inflate the bulb. Now can you show go to the internal camera again? So give me the suction. Make sure that there is no big ooze inside. Suction is not working. दूसरा suction दीजिए. Straight suction. So we know that there is no big bleeding inside, but we'll still reconfirm it before packing. So this airway will help in. Okay, so there is no big ooze. There is just a little trickle, little ooze from the surface, which will stop by this. Okay, so what we'll do is we'll put this pack inside along the floor. Now see how slimy is this. Just walks in. This is carboxymethyl cellulose, so it will just walk in without any resistance, and the same way it will come out also while pulling it out. दूसरा दीजिए, दूसरी pack. So, and then we can just inflate. Okay, inflate. Now ये दिखाइए, inflate करते हुए दिखाइए. You go to the external camera now. Yes, no, external camera. Show it here. Yeah. Now I'm inflating with around 8 to 10 cc's on each side. And then we'll measure the pressure. Our surgery is over. I've inflated with 8 to 10 cc's on each side. And there is a small hole for him to breathe. This is only useful for the first 5-7 minutes as he comes out of anesthesia. वो दीजिए, periosteum elevator. Just give me one moment. I'll show you that will inflate. We have a pressure gauge to know how much pressure we are applying. Now show this. वो जा रहा है. So now see this. Can you see this? So we know that we have inflated it beyond 120, very high pressure. This is only till extubation, right? Now since we have inflated it very highly, it can come out. So it will not bleed. Even if there is a little vessel which is say remained open, it will not still bleed while extubating. Because during extubation, if there is any blood which goes into the larynx, it can create problem. Now we'll just see inside. We'll check that there is no bleeding on the. ये लगाओ, ये पकड़ो. Suction. नहीं, रुक जाओ. We'll check that there is no bleeding inside the oral cavity. I'll show you if possible. Either from the nasal cavity or from the oral cavity. Yeah, endoscope दिखाइए. Go internal picture. So I'll show you with the endoscope. So सामने से हटो. Camera rotated. Huh? Okay. See, that was the. This was the area operated. This was the area operated on the left side. Both these area clean nahi hai. Okay. So there's just a little trickle from the top, which will stop in a few seconds. Andar dikhaiye light. I want it bone dry before Kalpesh extubates. Okay. I want it to become bone dry before he extubates. So even this little trickle, you can see the RBC is coming. Even this has to stop before he extubates, so that the thing is absolutely safe. And then if the blood pressure goes high, I'll ask Kalpesh, can you show the blood pressure now? External camera can go there. Yeah, show Shravan beech mein seto. Now see the monitor. The pulse rate is 74. So oxygen is 100%. Now you can reapply your base. And 108/80 is the blood pressure. If the blood pressure is going high, then what we can do? We can give a little bit of beta blocker and nitroglycerin, right? NTG and beta blocker. So that NTG will cause tachycardia. Beta blocker will stop that tachycardia from happening. NTG will not let the blood pressure go high, so that the operated area which we have left should not bleed while coming out of anesthesia. There are so many small checks that we always put, and I'll possibly show you the extubation live. ये सब करो ना, ये सब काट के लगाओ, चिपको साइड में चिपका दो, कोई बात नहीं. So now we are removing the endoscope and the camera. It's no more required, so that we'll clear up the space for Kalpesh to extubate. हाँ, ज़्यादा लाइट क्यों डाल रहे हो? ज़्यादा लाइट की जरूरत नहीं. Fine. It will glare, na? So now Kalpesh will extubate the patient. He has again reapplied the base. Show the base. The patient is in the range of 46. The base is 46, 48. It's coming up, right? So he will bring the base to at least 80 before he extubates, and if possible around 90. इसको सीधा रखो ना. Correct. Now see this, still the base is in the range of 40. This is the anesthesia range. We'll wait for the patient to come out. Kalpesh, how much time you think he is going to take? 5 to 7 minutes he will take to come out. So yeah, so let Kalpesh explain. Why do you wait for 5 to 7 minutes, Kalpesh?
Generally we want a complete
During
extubation we want complete dry inside the mouth, and we don't want any trickle of the blood. I generally wait for 5 to 7 minutes before I come out, because by the time blood will clot, all the clotting system will happen over there, and if by chance there is some bleeding which we don't want during the extubation, we can still have a time to the tackle. So no hurry in extubation is another important point when we want to extubate such kind of patient. We need to have a dry oral cavity, and we need to have a completely awake patient. These are the three factors we wait, and we wait for the 5 to 7 minutes for all these things to happen, and then we'll extubate the patient.
Yeah. So if you have any question, do you have any more questions over there?
None right now. None on the group.
So I think it will take around 5 to 7 minutes for him to extubate it, and another say 15-20 minutes before we intubate the other patient. And I'll try to show you the drug-induced sleep endoscopy. Abhi to time hai na. So we'll definitely take questions, but if required, we can possibly have another talk in that time, and maybe I can show you multiple drug-induced sleep endoscopies, if that's what you think is going to excite you more.
So there are a couple of questions. Are there any special? So are these leads disposable for the BIS? That the ones that you use,
yes.
Dr. Kalpesh?
They are single use. Yes, single use disposable.
What is the estimated cost?
1,000 rupees. 1,000 rupees. Okay.
So it's not very costly.
Yeah,
Right.
it's
It's
not
just $1,000, and you know that your patient is correctly sedated, correctly anesthetized, and is out of anesthesia before you extubate him. See, we are dealing with obstructive sleep apnea. So if the patient comes out of this deep sleep, his apnea will go away, right? So if your agents keep him into deep sleep, then there's a problem. If your agents do not keep him into deep sleep, or you come out of the deep sleep, you come out into the lighter sleep, then it will stop obstructing. So if you come out at the base of 80, 90, then you know that he's not going to obstruct on himself. Now there is always can you show the base now? And you must know, show the base first. Yeah, zoom onto the base. Zoom onto the base. You can see the base score at 70, right? 71, 72. Now he is out of anesthesia. He is still deeply sedated. So we'll want him to come to above 80. Can you show the lower one? Kalpesh, microphone to Kalpesh. Yeah, let Kalpesh explain what is this.
The lower one monitor, which is next to the striker system, is AGM. That is called Anesthesia Gas Monitoring System. Here what you see 0.1 and 0.3. Right, 0.1 is what the patient is inspiring as a sevoflurane, and 0.3 is what the end-tidal sevoflurane. Now the significance of this is that when the patient is having a more amount of sevoflurane in the lungs, patient is not going to come out very nicely. This kind of patient at 0.3 you can extubate the patient, but that's not the ideal scenario. So we wait for the complete removal of the inhalation anesthetic agent from the lungs. That is like 0.0 or 0.1. And at that time is the right time to understand that sevoflurane is not inside the body. And another parameter which you can see is nitrous oxide concentration and the CO2. That these two parameters are again giving me additional information for extubation of the patient.
So great.
Yeah.
So what we'll do is, I think Dr. Vikas has a few slides that he'll be sharing. We're just setting that up to share multiple DICE videos. See, what is important is there are two things. See, what we need to know is drug-induced sleep endoscopy. As you have seen, there is a lot of subjective observation variation. So there are studies which have shown that while starting out, when inexperienced person is doing DICE, his interpretation, his level of sedation may vary between two experts. However, over a period of time, as one gets more experienced with these procedures, it tends to be a little bit more reliable, and the observer variability, meaning what I would call as an anteroposterior collapse or as a concentric collapse, and what Dr. Vikas would call, would not differ once I have done say about 50 of them or 60 of them. But initially there will be a lot of confusion in terms of where to place the scope, how to position the scope, and so on. The other thing, I actually also would like a small message that the surgeries that you are taking up these patients may require some specific post-op care. So what is important is early on when you're taking up these patients, don't take up patients who are extremely obese, don't take up patients who have a very high oxygen desaturation index. You can take a person with a high AHI but not a very bad oxygen desaturation index. The younger the patient, the better. Because patients who tend to be more obese tend to require more kind of like in terms of post-op care, may require prolonged ventilatory support, they may take longer to come out. So it is always advisable to take up these patients where all the setup and a trained team is available. So are we ready with the next presentation? Yeah. So if you can just have the focus on the laptop, please.
Yeah. So what I'm going to show you is that one technique that we use in drug-induced sleep endoscopy is if we see the palate falling, and if we see that there is little amount of all well, Kalpesh? So when you are extubating, you let us know. So when we see that the palate is collapsing, and when we also see that there is some amount of collapse of the base tongue or epiglottis, then we need to be sure that after the palatal surgery, the patient will have a complete relief and will not require another surgery. So what we do is we put a nasal airway while doing drug-induced sleep endoscopy and then pass on the endoscope through this. Shaman, see. Could you see that? Now he is showing you the extubation first. Kalpesh is showing you the extubation. See, bis दिखाओ 90. Bis is 90. 1 sec. Show the bis at 90. Can you move one? Can you show the bis at 90? Yeah. See, the bis is at 89, 90, and show the patient. Okay. Patient is almost fully awake. He is finding it difficult because the nose is blocked. Naturally, that is going to be there. This is landing. So, at this point of time, the patient will always find it a little difficult. So now, Kalpesh has already extubated the patient. Now you can show the monitor. Sister. Now you can see the monitor. The saturation is falling a little bit. The base is at 90. Fine. So patient is, you can come on, you can come here. Come on to the laptop screen. So let's go back to our, so what we do is, LMA. So now what we are doing is, we are putting it, see, this is the nasal airway. And we'll go and see through the nasal airway. What the nasal airway is doing, it's keeping the palate open. So if we keep the palate open, and then see what is happening inside, then we know what is the effect of palatal surgery onto this patient. Now see, even when the palate is opened, so we can still see that the tongue base is not collapsing. Now this patient we have operated, he was from Patna and BMI was around 35 and very high HI, but you see he has just a epiglottic collapse. Even after keeping the palate open, his epiglottis is collapsing like omega 1. But we did only palatal surgery and he is doing extremely well, because this is because of the negative pressure. Partly we have tried to negate it by putting the oral airway. So this is one airway. Now we know that the epiglottis is, see, this is the palate. When the palate is collapsing, the epiglottis is closing more. When the palate is not collapsing, the epiglottis is not opening so much. So this is one way of knowing what will happen after the palatal surgery. Right. So in spite of this patient's BMI and AHI being very high, you can see that, yeah, you can see that this is again the lateral collapse. This is the tonsil. You can still see that this is only a palatal collapse. I'll again show you. Right, see, this is because of the pressure of the palate. That this is the Bernoulli. The tonsils are so huge, they are going almost down till the tongue base. Right. So now we can show the base again. Can you show this? Okay, Dr. Kalpesh, all well? Now you can show, yeah, this, show him. Yeah, show the BIS. Now see, the patient is consistently at 89, 90, 88 BIS. That means he is out of anesthesia and he is out of deep sedation as well. And see how easily he is breathing. Yeah. So even if the nose is blocked, there is little airway.
Show me your tongue.
Show your tongue. Okay. So that's it. So he'll be shifted in a few moments. Till that time, I'll show you few another drug-induced sleep endoscopy videos. If you have other questions.
So one of the questions that they have is, have you used the turbinator from Smith and Nephew, the blade to operate on the inferior turbinates?
Yeah, so turbinator is a good blade, but I believe it's oversized. The size of the turbinator is too big. Second thing is that, as I explained the concept in the turbinates are like this. If you see, this is the turbinate on my left side, it is like this, and turbinate blade is straight. So if you out fracture, then you can still use the turbinator, but turbinator works on the medial surface of the bone. The middle part of the middle surface of the inferior turbinate is not very bulky. Posterior part is only polypoidal. So it's not a uniform channeling that you have to do with the turbinator. You have to remove the posterior part completely, anterior part differently, lower part differently. Therefore, I do not feel great advantage with turbinator wand. I am a fan of the usual coblation technology, as you all know, but this turbinator wand, I believe, has to be still modified and made better. So maybe let me show you first the dice of the next patient who has got a tongue base. Now tongue base is a totally different ball game. There are a lot of things to understand. Maybe I'll come over and we'll discuss more about it. But if you see this patient dice, if you see him again, this is the soft palate, this is anterior, this is posterior, lateral. As you go inside, what is happening here? This is the anterior 2/3 of the tongue. You can see this is the anterior 2/3 and this is the posterior 1/3 of the tongue. That's the epiglottis. So is it the primary epiglottic collapse or the secondary epiglottic collapse due to tongue? That's the most important thing to ascertain. Here you can see that apart from the soft palate, this epiglottis is collapsing because he has got a big tongue base. This is all lymphoid tissue, and beyond this lymphoid tissue will also be muscle, because we can see the anterior 2/3 coming here. This is the foramen cecum. I believe that should be very, very clear. Yeah, this is the foramen cecum here. This is the anterior 2/3 and posterior 1/3, very, very clearly defined. Now there is no business going into the anterior 2/3 too much. We can just be here and remove all this part of the base tongue. Right, and then we need not cut the epiglottis. We'll do a glosso-epiglottopexy. We will stick the epiglottis, we'll remove the mucosa of this part of the epiglottis and remove this part of the base tongue, so that the epiglottis will stick onto this base tongue automatically within 4 to 6 weeks. So we are going to do a palatal surgery and base tongue surgery in this patient. Can we shift? Now see this, the complete collapse. So in this patient we expect some intubation difficulty, and Dr. Kalpesh also has to see this video. Now point is that this patient does not have a very heavy BMI. His mouth opening is okay. So with the laryngoscope that we have, we should be able to intubate him and extubate him easily. And his AHI is pretty high, 68 or 70 something, like 68 point something. So he has got a very high AHI but not a very big BMI. So he should get a very, very good result with the surgery. Okay. So Dr. Kalpesh is here.
So that recording is not here. It's not there. Okay, so let me show you a few more sleep endoscopies. Yeah, let me show you a few more sleep endoscopies. So now this is another patient. Again, we are using BIS. You see that the BIS is at 76. That means the patient is decently sedated, not over sedated. Below 80, 60 to 80 is the general range. And you can see that there is a little deviated septum on the left side. On the right side, you can see high deviated septum. Yeah, so there's a question. We'll take the question first. Yeah, go ahead.
So there is a question on the YouTube channel by Dr. Lalit Mohan Parashar. Do you give a slit on either side of the septal flap to prevent septal hematoma if there is a tear of the septal flaps?
Yeah, so it's absolutely a great idea to give a slit, and that's the reason I did not try to prevent a septal tear in this patient where there was a gross spur. So if there is a small septal tear, it is anyway good so that the blood will drain out. Only thing is that you should not give the tear on the same place, at the same level to prevent a septal perforation from happening. That's a very, very great idea. Anyway, we have packed the nose here, so there is no question of septal hematoma. And upper part septal hematoma we have already prevented by putting the gel foam. So let's come back to our next dice. Now see this, what is happening here? Yeah, can you see this? Now this, again there is a lymphoid hypertrophy of the base tongue. So you can very easily differentiate a base tongue hypertrophy of the lymphoid tissues from anterior 2/3 of the base tongue, which is more rough. This tissue, this mucosa is more smooth. You can see the junction very easily. This is anterior 2/3, this is posterior 1/3. And anterior 2/3 is not really responsible for the collapse of the epiglottis. If the anterior 2/3 is also collapsing, the best surgery is not a base tongue surgery. The best surgery is to pull the tongue forward, which is MMA.
Right.
However, MMA is a big surgery, so most patients will still opt for a base tongue surgery with lesser results. Now again, as you can see here, this is again a palatal collapse. So howsoever big is the AM, Kalpesh, I needed to show you the dice. See, Kalpesh has not seen the drug-induced sleep endoscopy. Don't come in the picture. Of the next patient, I am again showing you the dice. So see, this is the dice of the patient. You have seen him clinically, right? His base tongue is pretty big and it completely collapses here. So the moment you induce anesthesia, you will completely choke. So Dr. Kalpesh knows that the patient is going to completely choke the moment he is going to give anesthesia. So how are you going to tackle this?
This case is definitely going to be a difficult ventilation patient. Whenever I am going to give a sedation on a higher amount, patient will have a collapse of the upper and airway, and the tongue is also going to come in between. So I have to clear it out. I have two options. If I can put an oropharyngeal airway, that's a good option. And the best option is putting an LMA and ventilating the patient. And this maneuver of ventilating the patient with LMA before intubation is called Bailey's maneuver, which is very well described all over the world. In all the patients where upper airway obstruction or difficulty in ventilation, this system, this Bailey's maneuver has been described as a safety measures for the ventilation of the patient. So we'll keep both the things ready. We'll see how the ventilation is on without any additives inside the airway. If I am not able to ventilate this patient without any support, then we'll do the ventilation with an LMA, and we'll show you the Bailey's maneuver how we do it.
Okay, Kalpesh, how confident you are that you'll be able to ventilate this patient with LMA?
With the practice, and now once I have seen the patient clinically, The clinical
Mouth
parameters, yeah, mouth opening is good. The thyromental distance is good. The neck mobility is good. These are the three factors which are very important to understand about the putting the LMA of the patient. And in these situations, if the inside anatomy is not distorted, LMA are generally made in such a way that it fits very well around the glotte, around the vocal cords, and gives a good ventilation.
Correct. And then, is it to visualize the larynx, ventilation is fine. Now, when you intubate, how is the importance of the laryngoscope that you use?
Here, this is a very important question Dr. Vikas has asked about. The whole situation of intubation depends on the video laryngoscopy. We have been using our conventional laryngoscope since long, where our laryngoscope light is quite far away from the tip. So whenever we are looking at the vocal cords, we are not exactly into the angle. So what we normally do in laryngoscopy, that we try to get all angles match, all axes match in one direction by manipulating the patient's mouth, neck and the shoulder, and we'll try to intubate the patient. By doing a video laryngoscopy, we get the vision at the nearer to the tip of the laryngoscope. Our video laryngoscope, which we are using and recommending, that is a TrufaTech, that is called TrueView video laryngoscope, which has got 45-degree angle to the laryngoscope blade. Now this angle is very important to get away without a major manipulation of the neck and without a major requirement of the space inside the mouth. Here anatomical disturbance, here in anatomical situation is we have a large tongue. Now large tongue is often a obstruction in the vision also, in spite of having a good normal laryngoscope. So this video laryngoscope will make this intubation very easy by providing a clear view at 45-degree angle.
So there, yeah, you can take the patient and start intubating. So the issue that we need to understand is that in base tongue surgery, you have to understand the whole anatomy of the patient definitely. How is the requirement of air? How big is the BMI? Which part of the tongue is actually blocking? If it is only anterior 2/3 of the tongue, then the problem is only in visualization, not in ventilation. And the surgery on the tongue is not required. You can just visualize with laryngoscope and you will be out like the other patient. His base tongue was not big. His tongue was pretty big. You saw how he was struggling to put the scope. But he did not have any difficulty in ventilating, in extubating. This patient is leaner. That patient's weight was more than 90 kg. This patient's weight is much less. So this patient is a leaner patient, but he'll have more difficulty in intubation because of the moment you give anesthesia or relaxation, the base tongue will fall and completely block. So one has to be prepared for ventilation, then visualization, and during extubation. So these are three steps that you have to look into, and it's the lower segment of the base tongue which is most important. So more important than doing this surgery is to understand how the patient is going to behave when he comes out of anesthesia. Just saying that will keep him in the ICU is not enough. You really don't require an ICU if you understand your things well, because in ICU what you will be able to do? Nothing. If the patient is collapsing and is not able to breathe, you cannot do anything. What you have to do in the operating room. Yes, you can, where you require the ICU, if you are not going to extubate the patient, then you can keep a nasal tube and keep the patient in the ICU for 24 hours for the effect of anesthesia to completely go away and for the the chances of bleeding to completely go away in 24 hours. Let's start. Now what I'll do is we'll show you this patient. They are just preparing. It's all right. Just show the patient. See, he's a very lean and thin patient. Regular BMI around 28. So not obese, little overweight, but not much. So looking at his profile, nobody can say that he'll be a difficult intubation. But only on DISE, drug-induced sleep endoscopy, we know what difficulties we are going to face. And if we are prepared for those difficulties, we will not face any difficulty at all. Yeah? Yeah. So do we have any more questions, Rahul? Dr. Nilesh, is the sound quality, is the picture, everything clear over there? So we are definitely running behind schedule because a lot of things we have demonstrated, but I believe this will be also a very interesting case, palate and base tongue. And sorry. So if the patient also has a deviated septum and a big, turbinate, we have to decide which side we have to put the nasal tube in, because when we are doing base tongue surgery, then we have to put a nasal tube, because if you put an oral tube, the tube will keep coming in our way. So we have to decide which side. He doesn't have a grossly deviated septum, so we can put tube on either side. What is important is that while putting in the nasal tube, intubation or extubation, there should not be any bleeding from the nose. If the bleeding is there from the turbinates, then it will again create a lot of difficulty in extubating as well as intubating, because the airway is already compromised. Vision is always already difficult. So Dr. Kalpesh will take adequate precaution by preparing the nose first, go very, very slow. If required, he will use a nasal dilator first by a nasopharyngeal tube, and then only put the tube, the endotracheal tube. While coming out, while extubating, see, in any difficult intubation, if you put a nasal tube, it's more easy to come out. So if you do not pull out the endotracheal tube completely, if you pull it only out till the nasopharynx, you have a nasopharyngeal tube airway in place, which is lifting the soft palate up, so that the palatal collapse and the tongue on that, even if it is collapsing, the patient can still breathe. And now this tube, which we have already put into the trachea, when we pull it out, and do not pull it completely out of the nose, we have this tube into the nasopharynx. That means even if there is some kind of bleeding into the nose, we can always inflate the balloon and the bleeding will not trickle down. So we have two advantages of not completely taking out the tube from the nose. One is that there will be no bleeding because you have not taken the cuff out. Even if there is a bleeding, you can inflate the cuff and not let the blood go inside. And the third is that you have a nasopharyngeal airway in place. So these are small things that we have worked our way along. This is not textbook things. That's why live surgery workshops are, so that you know what actually we practice, and what all small innovations we do. So Rahul, your comments on this? No, about this keeping the tube in while taking out. Is this practice being followed anywhere? It's not. Yeah. So Dr. Kalpesh can comment.
There is a recent article on British Journal of Anesthesia 2017, most recent, that extubating the patient and keeping the endotracheal tube into the pharynx is been accepted, and it will be considered as a novice technique for giving a safety to the patient. So we are following this technique since long, and probably we will also come out with some literature on that.
Great. So I mean, these are small things that we have to keep on taking into our practice. So we know that this is a difficult airway situation, but I am very sure that Kalpesh will be able to do it nicely. He is keeping endotracheal tube, LMA, everything ready, and now is inducing the patient. At an appropriate point of time, we'll show you the intubation. Meanwhile, Rahul, you have any other question in mind? Use the microphone.
So in terms of the pre-operative workup, do you recommend a CPAP trial for these patients once they are diagnosed with sleep apnea, or most of your patients have already tried CPAP and their CPAP failed? How do you go about in terms of working up these patients?
Yeah, so last year we in our conference we came out with guidelines.
Sure.
Indian Association of Surgeons for Sleep Apnea guidelines, and all the guidelines say that the patient always should be given an option and a trial of a CPAP. Now, how long that has to be given, has it to be forced? That is a very individual thing to do. But I believe every patient should know about CPAP, and he should be encouraged to take a trial of CPAP. 1/3 of the patients will be happy with CPAP in general.
Right.
So if there is 1/3 of the patients, if they do not want a surgery, if they are happy with CPAP, if they are able to use the CPAP for long, there is no business of doing an airway surgery.
Right.
why should you take a risk of anesthesia, surgery, bleeding, pain, everything?
Absolutely.
Once we know that the patient is not happy with the CPAP, he is unable to use the CPAP, or cases in which we know that there is a big base tongue collapse like this. This patient also has tried CPAP for almost 2 months and he is unable to use the CPAP. You can understand that the CPAP closes the epiglottis further like a lid.
Right.
Because the base tongue is falling and the CPAP air is further closing it like a lid.
Right.
So especially the base tongue and epiglottis cases, which are almost 20-25% of all the cases, they would generally not tolerate CPAP. Right. It's not a question of compliance. It's a question of efficacy.
Right.
So the CPAP is not effective on them. So those patients, we definitely, while doing the dice, we know that this is not going to work for them, but we still ask them to use CPAP and see if it doesn't work. We say that the primary option for you is surgery. Sometimes we are not able to completely, we cannot give complete results in all the cases. So CPAP is always, there for a backup. If we are unable to give complete results, such as in high palate.
Right. So another thing that one must also glean through the literature is the CPAP compliance rates are traditionally very poor.
Correct.
So if you are going to prescribe CPAP to about 100 people, only about 30 will actually stick to it.
Correct.
So in terms of success rate, it's not that every patient who's not a good candidate for surgery may be a good candidate for CPAP also. I mean, weight reduction is one thing. I'm sure Dr. Vikas advises to everybody. And lifestyle modifications, cutting down, simple things like cutting down the alcohol intake, and also kind of like getting on a exercise routine.
So now Kalpesh is, can you show it here? Kalpesh is now showing the insertion of so he is inserting the LMA, as you can see there. So Kalpesh, your hand is coming in the way. Now if you see battery, hello, so no, my mic was a little away from my mouth. So now if you see here, he has already put in the LMA and is ventilating onto the LMA. Show the base. This is at 25. So complete relaxation. And you can easily ventilate the patient. See, the saturation is 100, pulse rate is 60, this is 26. Show the blood pressure. Show the blood pressure is 121 by 100. Now show the EtCO2 graph down. Now you can even see the EtCO2 which is put onto the LMA. So EtCO2 shows that the patient is getting properly ventilated. So we have everything in place for a difficult intubation. We know that these are the difficulties which are going to face. Now see, the base is 24, absolutely low. So completely relaxed patient, and still we are able to maintain the airway. So this also tells me that in case if the patient, let me speak from this mic, but okay, let me use this mic for the time being, but you check this one. Okay, now Sunil is going to show the. Are you going to show the intubation now? Now Sunil is going to, now see, this is the LMA in place. Base monitoring you have already seen. This is going to 17, very, very low. So now Kalpesh will show you the intubation live, and it's going to be a little difficult, but he's prepared for a difficult intubation. Nose में डाल दो ना तब. ये tube डाल कर रखो. So what should happen is that the tube also should be put into the nose a few seconds, maybe half a minute before, so that in case while putting in the nasal tube, if there is no, show it here. In case if there is any bleeding or anything, any difficulty, there is LMA to take care of that little trickle. And before
intubation, we have to be. Chalo, suction is ready. What size tube are you going to put, Kalpesh?
Actually, he is fit for 9 number.
Uh-huh.
Putting one size, one diameter low.
Correct. Correct. So he is trying a tube of 8 number, as you can see there. If this is also difficult, then we can try number 7. I think 8 has already gone in. 8 has already gone in. हाँ नहीं नहीं इस पे दिखाओ ना उस पे दिखाओ okay now he'll try to show you the intubation white balance हुआ है क्या now he has removed the LMA okay there's any bleeding from the nose no okay so see the tube is already there can you see that this is the tongue base this is the epiglottis see how easily he is able to maneuver oxygen बंद करो ना एक बार हाँ now see the he has already seen the epiglottis gone into the larynx and that's in right so very very predictable no bleeding now Rahul will talk to you I'll go to wash up so first palate now we'll do first the palatal surgery and then the tongue based surgery so that we create more into the palate space at the palatal wall.
So any specific questions, please forward them to Dr. Sharad or on the WhatsApp group. We can in the meanwhile also have a small discussion in terms of we can in the meanwhile also have a small discussion in terms of see what is important now in the post-op management is also pain control. So Dr. Kalpesh, would you like to yeah, so there is a question which is a repeat question, the cost of BIS monitor. So the BIS monitor, the one that we have here is I think is a Covidian. Yeah, it's about 2.5 lakhs and there is a disposable usage about 1,000 rupees per patient. But I mean it's a good tool, but it should not. I mean absence of this tool should not stop us from doing DICE or sleep apnea surgery. Now, in terms of post-op pain management, typically these patients take at least 7 to 10 days. So we need to counsel them that there will be some pain. However, with the coblation, the pain factor has gone down. It will take at least 7 to 10 days for these patients to go on to their full diet. We can do the routine tonsillectomy care. Only these patients are adults, so they cry more than the kids. For the post-op pain management, we can use NSAIDs. I've had patients where they were not controlled with NSAIDs, so I've used fentanyl patches for them. But most of these patients, I mean, by day 4, day 5, typically they would start to settle down, and the pain typically comes after discharge. So it will not come on post-op day 1 or post-op day 2. Generally, it comes a little later. Generally, it comes a little later.
Hello. This microphone is working. चलो कोई बात नहीं, तो मेरे इस पे पकड़ लेना. Just give me a moment. Hello. No, it's that microphone which is working. नहीं नहीं. Okay, you put the mic in front of my mouth. No? Check on your mobile. Show the माइक्रोफोन का बैटरी चेंज करना बेटा. नया लगाया था क्या? नया नहीं लगाया था. हाँ वो तो है ना इसके पास, लेकिन नया चेंज करो. Okay. I am really sorry for the delay, but you understand that this much time goes in, inducing a patient and preparing. So we are now ready with it. Can we put the microscopic picture into the system? Okay, microscopic picture please. Now shift on to the microscopic picture shown. Sunil, have you shifted? Yeah. Okay. So Dr. Rahul is leaving. Thank you, Dr. Rahul, for being here.
Thank you so much. It is always a pleasure to watch you operate in a live setting. And I'll be handing over the mic to Dr. Vikas now.
Okay, I believe the picture should be okay now. So we'll do the palatal surgery first. Again, as we decided last time, that anterior pillar to anterior pillar is a good landmark. Now since here the nasal tube is in place, we'll not be able to see exactly where the posterior pharyngeal wall is going to come, but I'll try to put my finger down the, can you see that? It's touching here. Is it visible? So now this is still again just above the line joining anterior pillar to anterior pillar. So let me start with the same technique of palatal surgery. I'll be a little fast on the soft palate because we have already explained everything last time. So this is the anterior pillar, this is the posterior pillar, this is the tonsil, the uvula. So if we take anterior pillar to anterior pillar, so the setting of coblator is 7 and 3. This is the anterior pillar, this is the anterior pillar. So I'll go anterior pillar to anterior pillar again. Now since we are not using laser,
So even if it touches here, doesn't matter. There is no thermal impact. Now see, there is some vessel here, superior pole, which you have to see and coagulate. Okay, you have to see and coagulate. This is the superior pole vessel. Now this is the musculus uvuli. Can you see this? Somebody has to. Now see, a big vessel here.
Yeah, seen very well.
So sometimes, yeah, Dr. Nilesh.
Yes.
Yeah. So Dr. Nilesh is here. Dr. Nilesh Chordia. Can you see the musculus uvuli very nicely?
Yeah, seen very well.
There was a, superior pole vessel on each side.
Yeah.
Right.
Yes.
But then those vessels are not really so big. This is the huge musculus uvuli, which I removed. Okay.
Yeah.
Now, just to make sure that there is no superior pole vessel here, I am coagulating first, and then I am going on to the right side.
Okay.
Okay. So this is the posterior pillar. This is the anterior pillar. So I'll go into the anterior pillar, little bit of anterior pillar, so that I can go into the supratonsillar fossa. Now, see, this tonsil is not looking so big, right?
Yeah, right.
But see, where is the upper pole of the tonsil? The upper pole of the tonsil is pretty high. This is the supratonsillar pad of fat. Sometimes the upper pole of the tonsil can be really buried. Here also it's going up. Can you see this?
Yeah.
See, this is the upper pole of the tonsil.
Okay.
See how it is going inside. Right?
Right.
This is all tonsil. See this? Here.
Yeah, seen very well.
Yeah. So I'll be a little fast because we have already discussed everything. In the first surgery, I'll be a little fast in order to save time because we are already running late. Going laterally. There's a cotyledon of the tonsil here. I'll reposition my microscope. ठीक है, बराबर है?
Yeah.
Now see how huge tonsil, though it was not looking so big, the tonsil plays a pivotal role in the palate being pushed backwards and causing sleep apnea. That I'll explain in the talk that we are going to have. Again, as we reach the lower pole, you can see there is a big lower pole. We will try to avoid a secondary bleeding in the post-op period by not exposing the lower pole. This is intracapsular dissection into the lower pole, because the lower pole of the tonsil doesn't really cause sleep apnea. This is the lower pole of the tonsil, which I am purposely leaving behind. Okay.
Okay.
So this is the lower pole out without exposing the tonsillar artery, and whatever little tissue is there, I am coagulating that also so that it fibroses. right?
Right.
Now we see very clearly the posterior pillar that we have actually got into. We'll leave the vertical fibers and we'll now these are the medial fibers which we have not completely divided. So let me divide the medial fibers completely. Tooth forceps. So you can see this medial fiber, correct?
Yeah, excellent.
These are the medial fibers which I divide. Palatopharyngeal fibers. Divide completely and reach the lateral pharyngeal wall. Once I reach the lateral pharyngeal wall, okay, can you see the lateral pharyngeal wall?
Yeah, seen very well.
So now this is the extra tissue. These are the vertical fibers. These are the medial fibers. So this is my plane of dissection. Okay, can you see them?
Yeah.
So the vertical this is the vertical fiber. This is the oblique fiber. I'm cutting through all the oblique fibers, but not the vertical fiber. And that's it. Very cleanly you can, right? And these fibers I am coagulating,
Right.
so that they fibrose, they do not cause any further obstruction. So just a coagulation from this raw area, preserving all the mucosa in the lateral and the posterior pharyngeal wall. See, this is the vertical fiber, okay?
Yeah.
So this will only fibrose vertically. This cannot fibrose laterally. This will not cause any stenosis. Okay, and this angle is 90 degrees, right?
Yeah.
Now we'll change this to the other side. See this, we didn't even take 10 minutes.
Yes.
I'll change the mouth gag to the other side because it's nasal intubation. It's much easier. You don't have to change the side of the tube. It will be much easier and faster. And
Correct.
another 10-15 minutes for this, and another 15 minutes to 20 minutes for the tongue base. So that's how we can plan for our next sessions in the auditorium. Okay.
So
now
nice.
this side will have a little difficulty because the tube will come here. But if the tube is really coming in our way, we'll shift the throat pack to the other side so that the tube is pushed little bit to the other side.
Right.
So we'll get some space. Because the intubation is done from the left nostril, so obviously the tube is closer to this side. Is it in center?
Yeah, center.
Is it centralized and in focus?
Focus. Excellent.
थोड़ा सा focus करो ना. Now this is the anterior pillar. I am going little into the anterior pillar. You see, that was the small vessel which I am coagulating. And now this is the posterior pillar muscle, which is the palatopharyngeus. This is the anterior pillar, posterior pillar. I am going into the anterior pillar to go supratonsillar. And we can see that the tonsil is going here. This is the palatopharyngeus again.
Right.
Since you can see the direction of the muscles very clearly, so you know that you can never cause a velopharyngeal insufficiency because you are not cutting the levator and the tensor palati. And this is the lateral pharyngeal wall, so I stop here We'll pick up the tonsil. See, as we anticipated, tonsil is going endophytic inside the. Okay.
Okay.
We have to pull the tonsil out. See, it's going there.
Yeah.
Quite lateral. I'll take the lux forceps. Microscope reposition. Go lateral to the tonsil. Check out if my sound is going okay.
Yeah, sound is excellent. There's a question.
Yeah.
What do you do to coagulate with cobbleter?
So there is a coagulation pad. I'll show you the coagulator in the last. So the yellow pad is for ablation and the blue one is for coagulation. So I am coagulating with the blue pad. With the yellow pad I am ablating. And for ablation you have to hover over the tissues. You don't have to press into the tissues. For coagulation you have to touch the tissues. So fine, this is the lower pole.
Yes.
Lower pole I'll go again intracapsular. So we'll not remove the whole tonsil at the lower pole. We'll do intracapsular dissection so that we do not expose the tonsillar artery. I'm again and again and again repeating this so that the newcomers at least understand what is the principle behind leaving that small tonsil. See, these surgeries are dangerous, but how we can make it safe, that's the whole idea. How to anticipate complications and take adequate measures to prevent complications. Unless you can predict and reduce complications, this whole field is not going to progress. We have also here Dr. Karthik Parelkar. Karthik, you have any questions?
Does this removal affect the resonance of the voice in any way?
So the question is that does it affect the resonance of the voice? It has to. No? It cannot happen that you alter the anatomy of the pharynx and there will be no change in resonance. So if you are doing this surgery on a professional voice user, say singer or an actor, definitely you have to work in more detail to understand what kind of change will happen and whether it is acceptable to him or not. Right? But on a speaking voice, this will not cause any problem. There will be hardly any change on the speaking voice. Okay? You saw this. This is the lower pole of the tonsil. There is no exposure of the tonsillar artery. And I am coagulating this little bit of tissue which was left there. Now, this was the... One sec. There is still some amount of fascia dissection. Let me complete. Now you can see the nostrils. So Kalpesh, how much time we have taken this time for the UPPP? 20 minutes, right? So this is our routine time. Generally for 20 minutes is the routine time we take for UPPP, but obviously that time I was demonstrating everything. So obviously it took a little longer. So UPPP is not a very difficult surgery if you understand the principles, if you select the patients well. Now see, this is the vertical fibers which I am coagulating.
Yes, seen very well. Yes.
And the fibers which are okay.
Excellent.
These are the fibers which we have removed. Now this is the vessel I was talking about. Sometimes this can be very big. You saw that?
Yeah.
Go right at the back of this vessel. Not only the tip. If you only coagulate the tip, then it can open after 10-15 days. 8-10 days. If you coagulate also the course of the artery, then it will not open up.
So do you have to ligate the vessel anytime, or it always is, or you can control it by coagulation itself?
See, initially when I was new to the technology, I did not have faith in the technology, and I used to coagulate to ligate the superior pole. Sorry, the inferior pole. Now I do not expose the inferior pole at all. See, on table, whatever is bleeding, you can coagulate with the wand. But having said that, did I ever have an opportunity to? I had to tie. Yes, I had to tie once. Not frequently. Only once. Okay, so we are done with the palatal surgery here. Let us see what was. I'm just coagulating the raw area so that it doesn't bleed later on, because we saw two big vessels on the superior pole. Okay, now we'll come to the tongue-based surgery. It's 11:30. I think before 12 we should be able to finish our tongue base so that the rest of the session doesn't get delayed. Now, CPAP failure. This patient is a CPAP failure because of tongue base. 45-degree endoscope. Tongue suture. What are you giving now? एक बॉन्ड और निकाल करके रखिए रेडी, पास में है ना. Okay, so external camera can show the preparation for tongue base. So we'll tongue खींचो बाहर. What we are doing is, yeah, are you showing? What we are doing is, Dr. Sriharsha Thalafule is pulling the tongue out so that I am taking a tongue stitch. I don't know if you are able to show it. A simple tongue stitch in the midline to keep the tongue protruded outside. Okay, and he'll take it on a artery forceps. Take it on a mosquito. 45-degree endoscope camera, please. Now, important is that when we put the mouth gag, this mouth gag I am changing. I am putting a smaller mouth gag. इस और छोटा भी है. Okay. इसके अंदर है. We'll see if this works fine. Generally, this is a number 3 mouth gag we use for the tongue base. Because if we use a longer mouth gag, it will also press on the base of the tongue. We do not want it to press on the base of the tongue. We are just getting the camera in. Okay, so now we're just getting a 45-degree endoscope because the correct angle is 45 degree. So we have to put a correct size mouth gag so that the base of the tongue is exposed and the anterior 2/3 of the tongue is not exposed. नया wand ready रखिए, लगाइए नहीं अगर नहीं चला तो. So what I am doing is pull the tongue out. Pull the tongue out. So we have to remain in midline. We are pulling the tongue out and applying the mouth gag. छोड़ दो उसको. चलो endoscopic picture दो. Let us see where we have reached.
How is the mouth opening of this patient?
Huh?
How is the mouth opening of this patient?
Mouth opening of the patient is not very bad, but through. चलो उसको छोड़ दीजिए, हटा दें. Mouth opening of the patient is not very bad, but the tongue is big, na?
Okay. Okay.
So now you are showing the endoscopic picture.
Yeah.
छोटा ये निकालिए, छोटा ब्लेड निकालिए. I think I can work on this. Okay, I have removed the throat pack and I'll show you the foramen cecum now. Can you see the foramen cecum? क्या कर रहे हो श्रवण, क्या कर रहे हो? चल जल्दी Okay, this is perfect. See, this is the epiglottis, this is the vocal cords, right?
Yeah, right.
This is the base tongue and this is the foramen cecum.
Yeah, seen very well.
Yeah?
Yeah.
This is the area of the foramen cecum. This is the foramen cecum, correct?
Yeah, correct.
Not yet. Not yet. So I am a little too inside. Anyway, I'll start from here. I have to come up to the foramen cecum, but I'll start from here because this is a little big tongue base. Let me start. This is the correctly placed. This is a little big mouth gag. So blade is little big, but let me start from here. So what we need to do is show from outside. Sunil, 9 and 4. So show on the yeah, correct. Now what I'm doing is, since I have to reach the vallecula, so I have to bend the wand. Bending of the wand should be done at the junction of the anterior 2/3, sorry, the proximal 2/3 and the distal 1/3. So there you have to bend the wand, but in a gentle shape, gentle curve. You can't bend the wand at an acute angle. Is it very well seen?
Yeah, seen very well.
Is the bend seen well?
Yeah.
So that now this wand will be able to reach the depth of the vallecula. Then I am sitting on the patient's side. There is a head low. Patient is always in head low position. Chalo. ठीक है, एकदम बराबर, ठीक है. Now the setting of the coblation I have changed to 9 and 3. It was 7 and 3. Now I have gone to 9 and 3. Okay. So I am holding the camera and the endoscope with my left hand, and my job is to remove all this lymphoid tissue and if required the muscle also, and go into the vallecula. You can see the epiglottis.
Yeah, seen.
And remove all this tissue. Don't move. Don't move. Now what will happen? You can see the saline. Saline will go into the larynx. Kalpesh, are you okay with the saline passing into the larynx? So saline is absolutely all right. Blood is not all right. So if required, we'll keep a very small throat pack.
There is a question on lingual artery. Do you still use the USG to delineate?
Absolutely, but only if the tongue base is really big. Question is that lingual artery, where it will come, do I use the Doppler? Yes. We use the Doppler if the lingual artery, if I am going very deep into the tongue, yes. Otherwise there is no need. So here we are going into the midline. We are not really going too much deep laterally into the muscle. So lingual artery is not in question at all. Yeah. Yeah. What is the question? Okay, can you see the muscle already coming into picture?
There is a question on YouTube live. What is the role of gabapentin or pre-GABA in post-op pain?
I honestly do not use gabapentin or pre-GABA at all. I simply give them combiflam syrup and if required ultraset.
No gabapentin.
No gabapentin.
No, gabapentin doesn't have here role because we don't want any kind of sedation in any form by giving to the any medication. So here we don't want to give gabapentin immediate post-operatively or later on also. And with this coblation technique, I would say that immediate post-operative pains are really very less and patients are easily manageable with paracetamol and Voveran.
Yeah, so immediate post-op pain is not a problem at all. Now see what I'm doing. I'm going onto this mucosa, making it raw at the same time. Can you see that?
Yeah, seen.
So this will cause glossoepiglottoplexy. Once you create a raw area on the tongue, can you see that?
Yeah, seen very well.
So I'm removing all this, but laterally when you go, if you go very deep laterally, you can hit small vessels, not the lingual artery, but you can hit at small vessels, which can bleed.
Okay.
So right now, see, this is the midline. This is lateral, right?
Yeah.
So when you go lateral, then you do not try to ablate too much. You try to coagulate more.
Okay.
See, can you see all that?
So how do you, is there any post-op edema? How do you manage that?
So if there is a post-op edema, now Dr. Harsha has already seen the clock. So it's 5 minutes of retraction. Is that correct, Harsha? So we will not keep the tongue retracted for more than 15 minutes at a time, because tongue is a skeletal muscle. After 20-25 minutes, it will start going ischemic changes. And if you keep it, see, can you see that what I'm doing? This is all lymphoid tissue. I'm first coagulating, then ablating, and then again coagulating, so that I'm removing this, right?
Yeah.
See, I have to go all inside. So at least I have to create a raw area everywhere. So after 10-15 minutes, we have to relax the tongue, because of ischemic changes there will be edema. Coblation per se does not cause any edema.
Okay.
Because it's not a heat driven technology. Right, so this is in midline. Now here I have to reach the median glossoepiglottic ligament. Okay?
Okay.
Can you see that? I am right at the median glossoepiglottic ligament. And I am coagulating it. I am not ablating there.
Yeah, seen now.
Right? So there's no, it's all raw. And there's all muscle. Can you see that?
Yeah, seen now.
So see, this is full muscle. So I have reached till the muscle, removed all the lymphoid tissue. I have removed this mucosa without any bleeding. So this will cause a good glossoepiglottoplexy. Okay. Now I'll come on to the left side. Maybe a little more of coagulation of this will help. But actually this is not the area which causes sleep apnea. The area causes sleep apnea is here. Maybe I can just do a little more of midline dissection into the muscle. And this you can just coagulate, because these are lymphoid tissue. Once you coagulate, they will fibrose.
Okay.
And this is not the critical area. Critical area was in the midline. Pani change. Now we need to go on to the left side. So what I'll do, it's already 10 minutes, right? 10 minutes. So I'll 12 minutes. So see, can you see the color of the tongue? It should not become dark.
Okay.
So I have released the tongue at 10 minutes or 12 minutes. So now we'll let it vascularize once again. Change this to the left side a little bit. No, that's fine. Yeah, what is the question now?
So there is a question on YouTube by Dr. Lalit Mohan Parasan.
Yeah.
Role of Ribagen as a mucosal healer in palate and tonsil adenoid surgery.
Role of?
Ribagen. R-E-B-A.
Yeah. That's a drug. I'm not a fan. Dr. Lalit
Mohan Parasan.
Yeah, I know him very well. From Delhi.
Yeah.
See, there is still some amount of, this is the paramecium. Can you see this?
Yeah.
This is the foramen cecum, right?
Yeah.
This is the anterior 2/3, this is the posterior 1/3. A little bit of tissue is still left here, which I'll remove. Uthaona. This is the correct. Can you see the foramen cecum very well?
Yeah, now seen very well.
Correct. So since I'll remove this tissue. See, the problem here in base tongue is that you cannot coagulate the arteries at the back. You can only coagulate them at the tip.
Okay.
So they can always open up later. That's the reason you have to be really careful. Now see, because this part need not be removed, right? Because this is not causing a airway block.
Okay.
In the midline, I am going into the muscle. There's a little bit of, I'll not go into this surface of the epiglottis. Now what we need to do is to keep the tube on this side. Correct?
Correct.
Because it is a left nasal intubation. So I'll ask Dr. Harsha, sister aap ye pakdiye.
So there is a question.
Yeah.
Is there any chance of aspiration after GE PEC-C, as epiglottis will stick to the base of tongue?
Not at all. In fact, it will take a lot of time, na? In fact, when we do epiglotectomy, then also that doesn't happen.
Okay. And will it hamper airway closure?
Not at all.
Not.
See, this will only pull the epiglottis forward. See, if you go and recall the swallowing mechanism, sister और उठाइए, ऐसे उठा कर और उठा करके रखिए, हाँ, keep it on that. If you remember the swallowing mechanism, it's the base of the tongue which actually helps in swallowing. It only pushes the epiglottis behind.
Okay.
We are reducing both, but it's only the extra part.
Okay.
See the midline, can you see that?
Yeah.
This is the lateral part. Lateral part really doesn't cause so much of airway blockage. So laterally, all the vessels come from lateral side, and the problem is in midline. So why you want to ablate laterally?
Okay.
You can only coagulate laterally, so there will be no bleeding. See this, right?
Yeah.
Now this mucosa is redundant, correct?
Yes.
So what I am doing is I am only coagulating this mucosa. And you have to coagulate right till the median glossoepiglottic ligament. Can you see that?
Yeah. See.
Then only there will be good fibrosis happening. See, there is no point removing all this. This is not causing any problem. At the most, if you want, you can just coagulate this and leave it.
Okay.
Even if you have to remove more, it's the midline which is the problem. So I am going into the muscles of the midline and removing a little more into the midline. Okay.
Okay.
Because see, if we are able to keep the midline open, that's more than enough. ये पकड़ो ना, ऐसे खींचो ना, ऐसा खींचिए ऊपर. Correct. Can you see that?
Yes.
That's the median glossoepiglottic ligament, which I am going to go and coagulate completely. No mucosa, because mucosa cannot cause fibrosis. So this mucosa I am only coagulating, so there is no bleeding. Now see, if you ablate mucosa, you will strip the perichondrium. It is only coagulation.
Okay.
The perichondrium is not lost, so there will be no perichondritis.
Okay.
Epiglottitis. Okay?
Okay.
So various things. छोड़ दो. निकाल लो. Now see this. In fact, even if this part is there, छोड़ दो इसको. Yeah, what's the doctor's name? See, even if this falls, this too will act as a bridge.
Okay.
So this is the bridge, these are the pillars. So when the tongue falls also, this will act as a bridge and the midline will remain open. This is minimally invasive surgery with minimal complications and maximum results. If you try to go too much laterally, do too much, you will get more complications, less additional benefit.
Okay.
Yeah, what is the question?
There's a question from Balagopal Kurup on the YouTube.
Yes, Dr. Balagopal.
Is immediate post-op OSS surgery sleep endoscopy of any use to predict healing? And does the ultimate result vary a lot due to the healing?
See, if we try to do sleep endoscopy immediately after surgery, the patient is already under the effect of anesthesia. So you will always over-sedate him, and even after a few days there is a lot of secretions and edema. So any sleep endoscopy which you have to repeat should be done only after 2 months, when the whole edema is gone. See, it's a multifactorial surgery, it's a multifactorial disease. So first of all, it's very difficult to decide that this is the only cause of his problem. Now this patient also, 68 AHI, we may not be able to bring it down to 0. It's not going to happen.
Okay.
Idea is to reduce his choking episodes, apneas to hypopneas. If we convert most of his apneas to hypopneas, we are more than happy. His risk of dying from this disease is reduced greatly. And now see, there's hardly any complication of this surgery. What we are doing, he'll be just in pain for 2 weeks. There's hardly any complication.
Okay.
If we do MMA, that will give him a better result. But this surgery, as you see, is over in less than 1.5 hours time. Okay. So though I can remove more.
Okay.
I can remove more. But see, I have already reached the muscles in the midline. I have removed the muscles also a little bit. Laterally, there is no real great need to remove a lot of tissues, because that will add to my complication rate, but that will not add. It's like hitting a 6. When you try to hit a 6, there is chances of getting caught. If you only hit a 4, there is no chance of getting caught.
Okay.
Correct?
Correct.
So I think I am done with the surgery. There is no bleeding. Kalpesh, वो अपना safeguard दे दीजिए.
Excellent.
There is no bleeding, and see, this surgery is going to help him, I would say, by 70 to 80%, not 100%.
Okay.
If I try to get 100% result, I'll get more complications. We have not gone deep into the muscles, so there is no chance of a big vessel opening up anytime. Now what I'm doing is I'm just putting a gauze, curved artery. I'm just putting a little bit of Sepguard, hemostatic agent, for half a minute. गीला हुआ है पूरा. We'll just keep it for half a minute to make sure that there is no. It's just a sense of satisfaction. There's nothing else. And this cannot stop bleeding. But typically we have been doing it, so I'm doing it. This is a hemostatic agent, which I'll just keep for a minute or so, half a minute, and then we'll remove it, and then Kalpesh will extubate. Kalpesh, how do you think he's going to extubate, easily or with difficulty?
Yeah, it looks to be an easy extubation.
Correct. This
is not a very big tongue base, and other measurements of this patients for airway are normal, so I don't expect major problem.
Fine. So I'll remove this throat pack now. Okay, so there's no bleeding. We have done just enough. We are not overdone. This is the palate. This is the tonsil. We see that the angle of this palate is, so this is just 90-degree angle on both sides. Can you see that?
Yeah.
It's a 90-degree. Lateral wall is absolutely intact. So we do not have any fear of nasopharyngeal stenosis.
They want to see the posterior aspect of mucosa uvula.
Posterior aspect of uvula cannot be seen because there's a, but it cannot be seen. There's no uvula anyways. Okay. We have removed the uvula, so we cannot see the uvula. Posterior aspect of the palate is hidden by the tube, so we cannot show that.
Okay.
Yeah. So we'll let Kalpesh extubate the patient, and possibly we'll show you the extubation as well. We anticipate some difficulty during extubation. If that happens, what Kalpesh is going to do? Is he going to just lift up and give ventilation? Go to the external camera. No? External camera. Yeah. So we are expecting some difficulty, not too much, because his mouth opening, his BMI is not very high, and his tongue base was also a small one. It was not a huge tongue base. We have done much bigger ones, but for a workshop, this is the perfect case to be shown. And we have underdone it. We have not again overdone it. I could have done more, but underdoing is always better. You never land up into soup, right? Whether it is tomato soup or chicken soup, you don't want to land in the soup. So now, if Kalpesh has any problem with, has any difficulty with extubation, what all he can do? He can lift the jaw, give a CPAP. He will keep the nasal airway. Apart from that, he can always push a LMA again, right? We know that on LMA, he could ventilate the patient very well. LMA is a very soft thing. It will go, his anatomy is good, so it will go and fit onto his larynx. If you try to put a instrument like Macintosh laryngoscope, then that is sharp. That will go and hit into the tongue base area which we have operated. It will start bleeding again. So, if we are very sure that our hemostasis is good, it is not going to bleed, then LMA is a very safe thing. If you are not sure about the hemostasis, then you have to put in the tube. So, what I did was to make sure that there is no bleeding, at least in immediate post-op. And late post-op, the chances of a big bleeding is very less. It might have a little, blood tinge, discharge, or little bit small capillaries opening up. Sir, do you give any dilute hydrogen peroxide gargles? Every patient gets a dilute hydrogen peroxide gargle. Why? Because oral cavity is full of anaerobes. Correct. And if you give an antioxidant, see, some people say you can give betadine, some people say you can give chlorhexidine. Chlorhexidine is better than betadine, but hydrogen peroxide is very good because oral cavity is full of anaerobic agents. And the moment you give a oxidating agent, let me come on this side. The moment you give a oxidating agent, all the anaerobes will die. So your anaerobic infection rate just goes down drastically. And with hydrogen peroxide, all the other organisms in the oral cavity, they are just, taken care of. So hydrogen peroxide 50-50 is the most important thing that we use. Along with that, chlorhexidine gargles. Then syrup, say all the medicines obviously can only be given in syrup form. So amoxiclav, the standard syrup, along with some ibugesic or say combiflam syrup, ibuprofen paracetamol syrup. Only if required, Tramazac or Ultracet. If the patient has too much of pain, then Ultracet, because it causes little bit of sedation. Now, it's not a bad idea to give a little bit of cough suppressants, because these patients have a lot of cough. If they keep on coughing, the chances of bleeding will be more. So we always give some cough suppressants to suppress the cough. Most important, Lidocam. If you give Lidocam gargles, it reduces the local pain a lot. Mucosal pain is taken care of by the Lidocam. So approximating the mucosa, leaving the mucosa open is no problem. There is no fibrosis because you have used coblation, you have not used cautery or radiofrequency. So there is no scarring, and the mucosal loss which has been there. See, I am telling you, sutures are more painful than this one, because sutures, you go inside the muscle and every time the patient coughs, there is a strain on the suture. They can break, they can bleed, and the pain anyways more. So this is always a much better idea not to put any sutures. Not only that, it is simple to do, but your patient has much lesser pain in spite of the raw area. Raw area pain you can take care of by Lidocam, local anesthetic. So, Harsha, what all we give? Dilute hydrogen peroxide, chlorhexidine gargles, Lidocam gargles. So 3 kind of gargles we give: Lidocam, chlorhexidine, and dilute hydrogen peroxide. And Dr. Harsha takes care of the post-op. So what are the commonest questions when they call you in post-op period? What is the commonest problem they face?
Commonest is, main thing is the pain. few
Correct.
people. The pain immediate first 2 days of post-op is not that much.
Correct.
But usually people
Third
call
day, fourth
after
day.
third day, fourth day.
Correct.
Usually whatever third day, fourth day till seventh day,
Correct.
there will be little increase in the pain.
Correct.
And that's bothers them because first 2 days was not there. And suddenly they are getting a high pain once again.
Correct.
They're little bothered. So we have to tell no, it's common.
Normal.
After 7, 8 days, it goes down. I
Right.
think by 10, 12 days, it's like having a sore throat.
Sore throat. Correct.
Only that much. That is the only one thing. And another thing is like the sensation of cough is there, something in the throat.
Correct.
Because of lot of this secretion getting collected. So that is the next thing there. And we advise not to clear the throat. Still, if it is there, let it be there. That feeling will be there as the days goes, like 15 to 20 days. Everything becomes normal.
Correct. And yeah, so anything else you guys want to add? And any questions we are getting on the WhatsApp group? Yeah, so we can show the nasopharyngeal airway. Yeah. So this is the nasopharyngeal airway. I'll just open it for you. This is the nasopharyngeal airway, with which many times we put it in the nose to keep the palate open to assess the result of palatal surgery, what is going to happen. And this is the laryngeal mask airway. Okay, so this is the LMA. This will go and fit into the larynx. Even if you put it blindly, the shape is like that, it will go and fit into the larynx. But obviously there are different types of LMAs. Some are intubating LMAs also. You can even intubate through that. So I think Kalpesh and the team will be able to tell you more about the airway management. But we are right now looking for the... Yeah, so if you're okay, you can start off with lectures because only the extubation is pending. And I believe it was great being with you all. So, and see, this is the way technology is going to take us. We are, we are sitting, say, 25, 30 kilometers apart and we are seeing it in high definition and, kind of almost real time, 30-second delays. But thank you very much for being there from the whole team of a specialty ENT. And let me just introduce my team member, Dr. Harsha. Sri Harsha is from Mangalore and he is going to be the next OSS surgeon in that region. Dr. Kalpesh is our anesthetist. Shaman, come here. Sunil, come here. So he is Sunil Patil. नीचे आ जाओ तुम. He is Sunil Patil. नहीं, हाथ नहीं ना. Sunil is the reason for all the audiovisual arrangements which have been done here, and he is an audiologist practicing in Pune. He was with me earlier. Shaman. And all the back-end arrangements are done by Shaman. He manages this place. And a big hand for Shaman for doing everything. Kalpesh has already talked to you, sisters. Sister. And our team of sisters, they have done an excellent job every time and we'll keep on doing that. So thank you very much. We can disconnect and you can continue with the lectures. I'll join you in 1 or 2 hours.
Excellent demonstration, Vikas sir. There's a great applause on WhatsApp, YouTube, and I'm sure there will be in the auditorium also. Thank you, Vikas.
Thank you very much.
Thank you.
Wow.